Amandla, 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 amandla. All power, all power. Let me take this opportunity, man, bakuthi ndizibulisele kumuntu wonke lapha endlini. Can we increase the volume kancane because there is this generator izasiphazamisa. Igama lami ndingu-Anele Yawa. I am the General Secretary of the Treatment Action Campaign and the Chief Accounting Officer of the Ritshidze project. Sizoqala ngoku because besithe sawuqala ngo-10 le nhlanganiso yabahlali ejongene kunye nemeko zezempilo apha Ekurhuleni. Xa siqala ndizawucela ukuthi siqale sifake ingoma but andiyazi uba ngeyiphi eniyithandayo. Andiyazi uba sifake yenkonzo okanye yomzabalazo. Chairperson, ikhona enye ingoma andiyazi uba siyakwazi ucula ke but ndiyazama okwam. Ikhona enye ingoma ethi kancane sekusele kancane kancane sizophumelela kancane sekusele kancane kancane sizophumelela Gauteng sekusele kancane Eastern Cape sizophumelela Limpopo sekusele kancane Mpumalanga sizophumelela kancane sekusele kancane kancane sizophumelela kancane sekusele kancane kancane sizophumelela Limpopo sekusele kancane Western Cape sizophumelela amandla 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 awethu qina mntu ophila nentsholongwane kagawulayo qina qina mntu ophila nentsholongwane kagawulayo qina. Thank you. Babe ngitshilo ke bahlali igama lami ndingu-Anele Yawa. Ndizawubhexesha le nqwelo namhlanje. I will be on the driving seat but andikho ndodwa. I am with my comrades. Ndizawucela ukuthi bazazise starting from the left.
Sanibonani nonke. Good morning everyone. My name is Lindiwe Mahlangu. I'm a district organizer of Ekurhuleni from Ritshidze project.
Sanibonani, Usthandiwe Maphumulo. I'm the key population monitor for the Gauteng. Thank you.
Morning, comrades. I am James Oladipo, researcher on the Key Populations Project. Thank you.
Thank you. Thank you. And also, colleagues, I must acknowledge phakathi kwethu in the room sinaye uKaifas Moloto, OE Deputy Director, Monitoring and Evaluation, HAST Directorate. Sibe naye uThemba Ngwenya, Deputy Director, TB HAST Directorate. We also online, I want to believe we've got colleagues from PEPFA, UNAIDS, CDC, USID, but amongst them all, we are also blessed today in this meeting by the presence of the MEC of Health, Umama Unomantu Ngomo Ralehoko. Before we start this meeting, comrades, I think it will be important for us to give MEC a few minutes to welcome us. I think MEC is disconnected. Maybe une network problem. Can I get a confirmation? We've got the MEC of Health of Gauteng. Sakucela MEC uvele video yakho uveze camera yakho sikubone. Sizakunika about 10 minutes usamkele MEC and then sizakuqhubha ngenhlanganiso kanjalo ke. Over to you ke MEC. Thank you.
Department, Mr. Malotane, Lisiba, because I felt that we felt both of us that it's important that we come and join you. Especially as Program Director, let me greet you, colleagues from Ritshidze, members of the community, invited guests, and ladies and gentlemen. I wish to express my sincere appreciation for the kind invitation extended to me by Ritshidze, granting me the opportunity to participate in this crucial community meeting. Our gathering today is dedicated to engaging in a profound discussion about various pressing issues within the realm of healthcare, with a particular focus on HIV, TB, and related services. I want to be upfront in stating that the Department of Health has been diligently working in these areas, but it is equally important to underscore the immense value of such meetings. They serve as a conduit for us to gain profound insights from communities, offering a platform for individuals living with HIV, both affected by TB and key populations, and other users of public healthcare services in our province to share their experiences. First and foremost, it is paramount to acknowledge the significant strides and accomplishment achieved by the Department of Health in tackling the challenges posed by HIV, TB, and other healthcare concerns. Our unwavering commitment to enhancing the health and the well-being of our citizens has resulted in the implementation of various programs, research endeavors, and resource allocation to combat these diseases. Our aim is to continually improve prevention, treatment, and support for those affected. However, the effectiveness of our efforts is closely linked to the valuable input and feedback we receive from our communities like yours. Community meetings such as the one we have engaged in today offer a unique and invaluable opportunity to bridge the gap between the healthcare initiatives and the lived experiences of those we serve. We recognize that individuals and families directly impacted by HIV, TB, and other health challenges poses unparalleled understanding of these issues. Your insights, your concerns, and your recommendations guide us in refining our strategies and policies, making them more responsive to the needs of our communities. Moreover, these meetings foster a sense of partnership and collaboration between the Department of Health and the communities that we serve. We view you as our allies in the battle against these health issues, and your active participation in these discussions strengthens our collective resolve to overcome these challenges. Through open dialogue and cooperation, we can develop a more effective solutions, ensuring that healthcare services are not only accessible, but also sensitive to the diverse needs of our population. In addition to discussing HIV and TB, it is crucial to underscore the significance of addressing the needs of key populations. Our commitment to providing equitable access to healthcare services extends to all individuals, regardless of their background and circumstances. By sharing your experiences and perspective, you help us to identify and address the unique challenges faced by key populations, allowing us to tailor our interventions more effectively. Program Director, I've been informed that Ritshidze will be presenting the data that they've collected today. I hold the hope that this data is not only honest but also accurate, as it could prove helpful in addressing any challenges we currently face. I want to emphasize that my intention in bringing up this matter is not to cast doubt on Ritshidze's competence or capacity to perform this task. Rather, my concern stems from the consistent criticisms leveled at the government by certain unnamed organizations, implying that we are inactive in addressing pressing issues. This situation has become more pronounced as we approach the upcoming elections, with various issues being raised for political purposes and misrepresentation. However, I must express my gratitude for Ritshidze's commitment to transparency by sharing their findings and data with us directly. This affords us the opportunity to engage with this information and foster productive dialogue. Such transparency is very important in building mutual understanding and collaboration among different stakeholders. In our democratic society, it is natural for organizations and individuals to hold differing perspectives and opinions about government actions and policies. While constructive criticisms can be instrumental in driving improvements, it is equally important that the information being shared is based on reliable data and accuracy. As we approach the elections, it is critical that we focus on evidence-based discussions and solutions rather than engaging in purely political rhetoric. The challenges we face in healthcare and other domains are real, demanding collaborative efforts for effective resolutions. Access to accurate data and open discussions enable us to work collectively and devise solutions that benefit our communities and the entire nation. I reiterate that my intention is not to undermine Ritshidze's work, but rather to stress the significance of transparency and open dialogue in our democratic society. I eagerly anticipate reviewing the data and engaging in meaningful discussions with Ritshidze and other relevant stakeholders, and ensuring that we can make informed decisions and implement actions and that positively impact our citizens. Your presence and active participation in this process are highly appreciated. In addition to examining this data, I want to mention that the ongoing importance of cooperation between government institutions, healthcare organizations, and civil society. Collaboratively, we can leverage this data to craft targeted strategic programs that effectively address our community's healthcare needs. It is imperative that we prioritize the health and well-being of our citizens over political considerations. Moreover, as we delve into this data, let us acknowledge the firm dedication of healthcare professionals and frontline workers. They have been working tirelessly to provide essential services, especially during these challenging times. Their commitment merits our efforts, respect, and support. By building upon the insights shared today and working in synergy, we can ensure that their efforts yield even more substantial and positive impacts. As I conclude, Program Director, I want to express my appreciation to your participation in this meeting. Let us seize this opportunity to cultivate an environment of openness, an environment of cooperation, and an environment of data-driven decision-making as we collectively strive to enhance healthcare services to all our citizens. Thank you so much, Program Director, for the opportunity. I truly appreciate.
Siyabonga MEC, siyabonga ngamazwi akho, with the hope that xa sigqibezela eyokugqibela meeting, because we've got other 2 meetings eTshwane and the other district, we will reach out to you MEC for a meeting as the TAC in Gauteng and the sector of people living with HIV, so that we can discuss these issues further. Thank you MEC, siyabonga. Colleagues, as we are moving with the program, I want to acknowledge Dr. E.M. Tipoy, the Acting Chief Director of Ekurhuleni Health District. Also, acknowledge Mr. James Letswalo, a Technical Lead Care and Treatment from VETS, as well as David Ngwana, Senior Program Manager, Wase VETS RHI. All of you, you are welcomed, and nani bahlali abasandungena, you are welcomed. Namhlanje, today we are having this meeting here. The meeting here today is based on a report, Ritshidze, that we are releasing, a focus on the state of health Ekurhuleni. Ritshidze is a consortium of 5 organizations: NAPWA, TAC, PWN, Sanarela, and Positive Action Campaign. The duty of these organizations and Ritshidze is to monitor equality of HIV and TB services, more especially kwezi facilities that are supported by PEPFAR. We are monitoring ukuthi abantu who are HIV, people with TB, the gays, lesbians, transgender, queer, people who are using drugs, sex workers, men having sex with men, whether xa besiya eziklinik beyofuna, including umphakathi, xa abantu besiya eziklinik baya ngenhliziyo emhlophe baphume inhliziyo isemhlophe okanye kwenzeka ntoni na. Because we've got a problem in South Africa around 95. The second 95 and the third 95, we are not doing well around the retention to care as well as adherence. In South Africa, sizakhumbula ke ukuba in South Africa we've got more than 80 million people who are living with HIV. And less than 6 million people living with HIV are on antiretroviral treatment. We still have about 2 million people plus who are not yet initiated on treatment. But when we look into the 6 million that is on treatment, things are not looking good. People are disengaging on care, but decide ungayi eziklinik. Onesi abayazi why abantu bengayi eziklinik. So today we are creating an opportunity for abahlali to be able to share their frustrations. Xana ungena eklinik kuthiwe hey wena une AIDS bonke abe AIDS ngapha, how does that make you feel? Xa ungena eklinik being a gay ubizwe ngelinye igama okanye as a young person uze eklinik for i-services of i-termination of i-pregnancy, udibane nonesi akushumayeze akuxelele ukuthi mntanam uzoqhomfa ngoku, and ukuqhomfa akusoze ungene izulu abe umuntu omtsha engayelanga uyoshunyayezwa eklinik eyele for i-services. So we want to discuss these issues. Bakhona abaphathi be-department so that abaphathi be-department can be able to understand our side of the story as the community, to say what makes us to disengage on care, so that all of us, we can work together in terms of fixing the problems that we have. Because at the end of the day, this is all about saving the lives of the people. But also in the process of saving the lives of the people, we must be in a position to respect the constitutional right of the citizens. We have to respect what is called the Patients' Rights Charter. We have to also respect the human dignity. So that when I wake up in the morning as Aneleyawa and I go to a clinic, I go with my dignity intact. When I get there, my dignity is still intact. And when I walk out of the clinic, my dignity is still intact. So how best can we work together in making sure that we're fixing the problems that we have and ensure that no one is left behind? So our report again, we've got a written report ezavezwa phana. Bakhona abahlali abakhoyo apha in the room abaze phambili bathi bona umna I am willing to share my story. Bakhona those who are recorded, they will share their stories. So inkqubo yethu ya today kule programs, we will look on issues that are related to staffing and waiting times. So focus on issues related to collection of antiretroviral treatment. We look at issues that are related to continuity of ARV, ART, issues related to key population, index testing, infrastructure and clinic conditions, and lastly, si focus kwindaba ye-TB. And then after that, we will give to kuma organizations akhoyo apha, NAPWA, Positive Women's Network, Sanarela, TAC, 2 minutes, 2 minutes, 2 minutes each. And then after that, we will give to each department to respond. But before we go to the program, I hope that the MEC or someone from the office of the MEC is still connected. Sinengxaki South Africa. I'm sure sivile ngexesha lala mid-term budget speech ye-National Treasury uTata uGodongwana uzile wathi department we are planning to cut 1 billion from e-health, and that 1 billion ezawukhathwa yile kanye ijongene kunye nenkonzo ze-HIV and TB. Basiyakhumbula not long ago the National Department of Health izile yathi kukho ipolicy abayipasisileyo ye multi-month dispensing of medication. If anele yawa you are living with HIV, you have been on treatment and you are stable on treatment, why do you have to go to a clinic every month? If you stable, sizakunika treatment ye 3 months or 6 months so that you don't keep on coming to the clinic every time and again. And declare budget cut akhona mahemhem athi izawuchaphazeleka indaba ye multi-month dispensing of medication kwi-budget cut. Akhona mahemhem athi izawuchaphazeleka umcimbi we-prevention PrEP for young people, key population who are HIV negative. There is what is called the PrEP. Le uyisebenzayo to prevent yourself izawuchaphazeleka, and other programs. Kuthiwa xa zibuzwa inkokheli zethu abominister ukuthi nizokwenza njani ke ngoku because niyakhatha ngapha nizayifumana phenye imali yokwazi uvala le gap, bathi xa bephendula we do have development partners in the form of the Global Fund, PEPFAR, and all what have you. As the PLHIV sector and SANAC civil society, we are mobilizing communities in KZN in preparations of the World AIDS Day and somewhere around all provinces. We are saying to our government, to the Deputy President, as the chairperson of the South African National AIDS Council, we are saying to the Minister of Health and all MECs, let's work together to push back and make sure that the Treasury does not cut this budget. Because if the Treasury is cutting this budget, many people living with HIV and TB are going to die. We remember what we went through during the time of lockdown. Mid-2020, around June, the National Treasury took about 3 million from HIV conditional grant by Investec with response on COVID. That's why today we've got a high defaulter rate. That's why today we've got almost to follow up abanenzi, because during the time of COVID, the priority was COVID. HIV and TB were no longer a priority. So it is important that we work together. If it means all of us, we must go and occupy the Treasury and say, Treasury, stop this. Colleagues and comrades, the unfortunate part that we have in South Africa, you know, we have been hearing government, the Treasury, bailing out state-owned entities. If SAA tomorrow angavala, ukhona British Airways, ukhona Fly South Air and other airlines. If Eskom angavala today, nansi outside the generator yaqhuma, zikhona solar. But if umntu oyi-1 dies, we do not have a spare life that we can take to save the life of that person. If it is easy for our government to bail out or Eskom and our SAA, why our government and our political leaders are not keen to bail out our health system? Because our clinics are still small and are still in bad conditions. We're waking up as early as 4 a.m. to queue in those clinics, only to be attended at 10. At 12, you are told, go home, asnamayez. Yet, in that process, you traveled long distances to and from. At times, people wakes up as early as 4 a.m. I-clinic ivule ngo-8, umuntu aphume ngo-4 egeyitini ye-clinic, engakhange atye. This is the life of a black person in South Africa. This is the price of the freedom which we fought for. And if we accept this situation, all of us are going to die. We need to use our anger to put pressure to those in authority. The reason today we are standing here boldly and proudly and saying more than 4 million people are on antiretroviral treatment, you must remember, it was not because our government was willing to do that. We had to fight with the government of Thabo Mbeki and Mando Tshabala Msimang, who wanted people living with HIV to die and go, and they said, we cannot take ARVs, they are toxic, we must eat garlic and all what have you. Look at us now, we are beautiful. More than millions and millions of people are living a healthy life. And if we had listened to Thabo Mbeki, more than 4 million people could have been dead today. That is the same energy and the same anger we need to use to fix the broken public healthcare system. So without making State of the Nation address, I was trying to put ingqondo zethu together and understand why are we here and what is it that we'll be discussing about. Without wasting any time, I will hand over to Kombetu James and lead us on issues related to staffing and waiting times. Over to you.
Thank you so much, GS. Today we have launched the 4th edition of the State of Health Report for Gauteng, developed using data from Ritshidze's community-led monitoring. Ritshidze's monitoring takes place on a quarterly basis in 128 facilities across the province. This week we would hold 3 district community meetings, today in Ekurhuleni, tomorrow in City of Tshwane, and Thursday in Johannesburg. We will be deep diving into both the progress and challenges across the 3 districts, and hear directly from people living with HIV, people who use drugs, sex workers, LGBTQIA plus community members, and other public healthcare users as to the real experiences using clinics in each district. Today, we start with Ekurhuleni, where we monitor 40 facilities. Data are collected through observations as well as interviews with healthcare users, which includes public healthcare users, people living with HIV and key population, and healthcare providers, which include facility managers and pharmacists. Data in this report was collected between July and August 2023. Interviews took place with 40 facility managers. Observations took place at 42 facilities. Interviews took place with 2,145 public healthcare users, which 50% identified as people living with HIV and 14% identified as people under the age of 25. Additional data was collected between July and September 2022 amongst community of key populations. Interviews took place with 47 gay, bisexual, and other men who have sex with men, 308 people who use drugs, 273 sex workers, and 31 trans people. First group of issues are on staffing and waiting times. Improving the state of healthcare services provided at our clinic so that all people living with HIV and key population can access friendly, welcoming, and quality services depends mainly on having enough qualified and committed staff in place. This year, only 42% of public healthcare users interviewed reported that there were always enough staff at the facility. This has worsened slightly from last year when 46% of people said there are always enough staff. The best performing sites are outlined in the table as shown. The worst performing sites are outlined here. From the perspective of facility staff, only 22% of facilities monitored reported that there were enough clinical and non-clinical staff to meet demand, down from 33% last year. There is still a way to go to fill the human resource gap because 78% of facilities monitored remain with too few staff to meet demand. Of facilities reporting shortages, 19% of facility managers blamed there not being enough open positions on staff shortages, while 55% blame staff shortages on one or more unfilled vacancies. According to facility managers, the most commonly understaffed cadres were professional nurses, enrolled nurse assistants, and data capturers. There were 137 vacancies reported in this reporting period. The highest number of vacancies by cadre are by far professional nurses, followed by cleaners. 68% of facility managers we spoke to specifically wanted additional human resources for health support from the PEPFAR district support partner, VITS RHI. However, PEPFAR's funding for critical HR posts has only reduced in recent years. Average waiting time have reduced by 22 minutes in the last year in facilities monitored in Ekurhuleni, down from 3 hours 39 minutes to an average of 3 hours 17 minutes waiting in the facility. This includes the time before the facility opens. And waiting time after the facility open has also reduced from 3 hours 18 minutes last year to an average of 2 hours 57 minutes waiting after the facility opens this year. However, there are still 23 facilities that had waiting times over 3 hours as outlined in the table, with 7 facilities with waiting hours over 4 hours. This means that some public healthcare users still spend hours in the facility, and this is a major source of dissatisfaction for those who experience the long waits. 34% of public healthcare users interviewed in the district think the waiting hours at the facilities are long. This has improved since last year, where 45% of public healthcare users thought the waiting times were long. 42% of public healthcare users blamed long waiting hours on staff shortages, and 32% blamed staff not working or working slowly. While 85% of public healthcare users were aware of clinic appointment systems, only 36% report getting both a date and time, and 60% reporting just getting a date. This means people arrive early in a cluster in order to get seen, and the clinics are empty by the afternoon. Appointments could be spaced out throughout the day to ease congestion. Filing systems were observed to be in a good condition in 86% of sites monitored, just up from 85% last year. Those reported in bad conditions were mostly due to filing rooms being too small to maintain, and 24% of public healthcare users blame long waiting times on messy and disorganized filing system. Messy and disorganized filing system increased delays and increased the burden on already overstretched healthcare workers. The average earliest arrival time has also improved, from 6:04 a.m. last year to 6:32 a.m. this year. But some people still begin queuing early in the morning in an attempt to get seen more quickly. 17 facilities monitored still had an average arrival time before 6 a.m. Of 818 people who arrived before the facility opened, 19% reported feeling unsafe or very unsafe while waiting for the facility to be opened. While a circular was issued in May 2019 by the National Department of Health, calling on facilities to open by 5 a.m. on weekdays, none of those monitored even opened before 7 a.m. Commonly, facility managers tell us that they are unable to extend opening hours due to insufficient staffing to cover this time. Only 55% of public healthcare users think that facilities are open for long enough, and 55% think that extended hours would improve access to healthcare services. We now move to recorded stories.
Okay, mina ngihlala emaphupheni ngihamba ePhilip Moyo eclinic kunezinto ezingangiphathi kahle mangiya ePhilip Moyo cause each and every time mangiya khona bayasitesta for HIV. You know, it's a must, you must have that paper, the paper lela bakunika lona ukuthi istatus sakho sinjani. bakubuza igama lakho nesibongo ne-age, then bakutest. There's no counseling, akuna-next. Then abakutshela ngokukutshela ukuthi upositive.
Uhambi ungaka-attend. Ngisho ukuthi yonke indawo yazi, yonke indawo because isemafayilini uyahlala uyalinda.
Shuthi bengihamba ikliniki yasemkhathini endulweni. Yeah. Shuthi i-service yakhona akusi-service yokuthi ishapu abantu bakhona abaslow bacwele ukudlala and manje masekliniki singabantu kumele kube umuntu ovuka ekuseni ngiyofika le ekliniki ngize ngiyo-attendwa ngabo 11 12 mara ngisuke endlini ngo-4 ama-sister wakhona abo-doctor bakhona barude yabo bane-attitude indawo iklini isharp just i-service yakhona barude babehave njengabantu basethembisa hospital ya banginika i-prep ukuthi solala maybe kumele ngicale ngisebenzise for 7 days izocala ukusebenza yona after 7 days yabo mara mina ngaba nenkinga naleyo prep yabona ngoba kimi ngithi mangibatshela nanoma ngibheka kimi sefana nokuthi ngathi ngipositive yabo ngoba mangabe ngizoyidla ngidle egcineni ngingasayidli what will happen to me abangichaziseli lokho bangitshela ukuthi lento le ifana ne-prevention but they don't be specific ukuthi ama-infection wayo if ever mina ngizoyisebenzisa njengomuntu odla ama-ARVs makazowadla wani angasawadli makaceda.
Mina ngihlala ama-7 khona la eThwatha le phezulu Kingfish hlala lapho ngihamba eklinikhi la ema-14 Philip Moyo yeah 8:30 khani to 9 khani baqala bathatha amafayili uthi uyafika khona mhlawumbe ifayili yakho ayikho seyile bakuthi ilahlekile le nginayo nje busifo manje le nginayo le manje sabaqalile sabasebenza kahle 7 sabaqala manje basahlala ekliniki manje hayi mina ngicela ukubona last month bengikhona ngicela ukubona last month masahlile awu 7 sabasibiza mhlawumbe biza 6-5 ngithi mina ngabe kwenze njani basibize elanga phela lana siphela hlala lapho 8 khani basiqala namanje namhlanje bangifikile nje bacala 7.
So ngayohlaba bathi ngibuye ngoJune la eBarcelona clinic. So mangibuyela ngaleyo date abangiphe yona futhi ngabuyela ngo10 because the appointment yami ngo11. Mangifika bangitshela ukuthi hayi abone sebahambile and ngamangala ukuthi hawu because bathe ngize ngo10 ngo11 manje mina ngize ngo10 sebahambe kanjani. So ama security lapha egate ngitshela ukuthi hayi ngoba sebahambile ungaya eJoy. So azange ngiphinde ngibuyele vele mina. Bathi Friday yabone sibachayisa ile. Lo siso sebenza lapha reception vele naye wangitshela the same thing. Yeah, into abajwayele ukuyenza bona vele ukuthi ngama Friday bavala ile.
Firstly, I started staying here, going Kamuvela Kopano. Then Kinka treatment ya Kamo for HIV. Then right now really young people that we have HIV. Artola special treatment thing. They just keep telling us we're going to get treatment yarona, and we are doing definitely that. No worry, I can come here Kabo 8, then around Boma 12, Ngano Baketa Mile, if we are not too many.
Yeah, like it's definitely clinic aina snege, especially futhi nasebantu abadala. Oda kungapha ngapha nje kuhlangahlangene abaningi like find more people to help because staff sakhona sincane and like I think especially young people they don't have like patient like ngumuntu omusha so clinic ngiexpecta ukuthi abantu abasiza abantu like babe abantu abakwazi ukunderstanda abanye abantu bangamani bahluthuleke nje ebantwini.
We now move to community members that have joined us in the room.
Okay, igama lami Zinhle Mthethwa. I attend the clinic in Barcelona.
I attend Barcelona Clinic.
Okay, I went for my annual blood test. Bangishaya isandla bangatholi ipulse yami. After 7 times bayithola. The following day my hand was swollen.
I went for my viral load annual test, and they tried to look for the pulse in my hand for several times. They could not find it, but eventually they did. But the following day my hand was swollen.
When I go back to the clinic, they told me ukuthi abazingeni. I should go back home ngizozipholela.
When I went back to the clinic, they told me that it's not their problem, and I will see what I do with my hand.
The nurse was very rude.
Unesi beka ngakhulumi nami kahle.
Thank you.
Ngiyabonga.
Sanibonani, igama lami nguSimangele Sindana. Nge-22 zika June bengiyethafeni clinic ngiyopepa.
I went to Tafeni Clinic on the 22nd of June to give birth for antenatal.
Mangifika khona ngathola usister beka rude for mina.
When I arrived there, the nurse that was present at the moment was very rude.
Ngalesikhathi ngimile kwaphuma amanzi kwawa nenyama, and then ngaba shocked ukuthi kwenzakalani, wathi cleaner.
At the time that I was still standing, I saw water and some clot kind of coming out of me, and the nurse told me that I must clean.
Mangisacleaner wathi usebenza lana wena, gibela phezu kombhede.
When I was still cleaning, then she said to me, "Are you working here? Climb the bed."
And wangipusha athi gibela, ngagibela.
And she pushed me, insisting that I should climb the bed.
Mangibela athi push umeleni, melu pepe.
And she told me to push because I need to deliver the baby.
Mangiceda ukudeliver ngableeda too much, wathuka.
After I delivered, I bleeded a lot, and the nurse got scared.
Wangidisha wathi ayi kumele ngihambe ngiyethembisa hospital because akukho right ngibleeda too much.
So after she did some stitches on me, she told me that I need to go to Tembisa Hospital because I was bleeding a lot.
Mangifike eThembisa hospital kwamele bangistishe again la ngistishe khona ungenze wrong.
When I arrived at Tembisa Hospital, they need to perform another procedure because the procedure that was done was incorrect.
Sanibonani.
Greetings.
Usithabile Zulu. No. Qhamuke ePhenduka Clinic.
I'm from Penduka Clinic in Katlehong.
Mina okwangenzakalele clinic ngangihambisa umntwana ngafika around 5 khona ekseni.
I arrived around 5 a.m. in the morning when I was taking my child to the clinic.
Umntwana waye eqhuma nje ungathi kubhlungu somewhere.
The child was in pain.
Kwahamba kwangathi kuyaqinisa ngase ngale gate lama security ngiyocela ukuthi bengifonelele iambulance or bengicelele unesi okhona ngaphakathi eclinic.
And as I was still queuing, it seems the child was getting worse, so I went to the security to request them to call an ambulance or maybe call in the nurse from the clinic.
Akazange ngithole usizo ama security kwangabantu besifazane beba3. Oyedwa wayengathi ufuna ukungisiza kwaba khona umunye wathi akusiyo umsebenzi wakhe lo ukuthi angifonelele ambulance angiyifonelele mina iambulance.
So on duty there were 3 securities. The other one wanted to assist, but the other security said it's not your job. So they told me that I should call the ambulance myself.
Wasethi lo ongafuna umunye angisize wase wathi angivula umntwana ngimphumphuthe la enhlokweni mangiphumputha ngathola sekushone la phakathi ngathi mina kunembobo.
So the other security that did not want to assist instructed that I check the child and puputha in English and blow some air into the child's forehead.
Wasebangitshela ukuthi ena ngithi niyahamba nihambe niyochatha abantwana nibuye nize la ekliniki angayikho into esokusiza amanesi awakafiki uyazi mos ukuthi kuvulwa ngo-8 la.
And then the security further alluded that you take kids to different places where they give them medicines, and now you come here, there's nothing we can do for you. You know that the nurses are not here yet.
Ngaze ngacela omunye-ke umuntu ukuthi uma ngifonisa so ngokubona kwakhe wase wathola ukuthi uma ngifonela i-ambulance wase wathi uyangikhapha ngendlini wabona ukuthi umntwana useshonile.
So by the time somebody agreed to assist me with the phone to call an ambulance, they then said it's better for them to take me back to my house because they noticed that the child was dead already.
Angisakhona ukuthi ngihambe ngithathe i-treatment yami ngoba mangiyakhona ekliniki kuvuka yonke into.
Currently, I cannot even go back to the clinic to collect my treatment because every time I go to the clinic, I'm reminded of the situation that transpired in that facility.
Sanibonani.
Greetings.
Mphakathi angeke ngikwazi ukuzisho igama lami kodwa ngihambe ekliniki eMkhathini.
I attend Mkhathini clinic.
Mina njalo mangiya ekliniki nginenkinga yokulahlekelwa ifile.
Every time when I go to the clinic, they can't find my file.
And mele ngivule ifile elisha.
And they have to make a new file for me.
Mangivule ifile elisha kumele ngiqalele phansi ngithathe ama-test amasha futhi and always kumele ngenze kanjalo mangabe ifile lami lilahlekile.
And this has happened often whereby if they can't find my file, they need to start me afresh to draw bloods, and this takes time.
And enye into bazongibuza nge-treatment yami ukuthi ngiphuza yiphi treatment while bangazange mina bang-explainele ekuqaleni ukuthi i-treatment engiyiphuzayo yeyiphi. Inkinga yami yileyo futhi ukuthi i-treatment abasichazeli ngayo.
The other problem is that in the process where they can't find my file, they'll then ask me what treatment do I take. And this is a problem to me because I never received any explanation to what treatment I'm taking. The clinic never explained to us what treatment you take.
Yeah, because sometimes mabangibuza ukuthi which treatment engiyithathayo ngisuke ngidideke ngingazi ukuthi ngizophendula ngithini ngoba nami ngisuke ngingayazi treatment yami mabangazama nje ukuthi basifundise nge-treatment esiyithathayo singakubonga kakhulu lokho.
Okay, so when they ask me which treatment I'm taking, I get confused. So I'm requesting that the facility can at least explain to us what treatment we are taking so that we know. Thank you.
Sanibonani.
Greetings.
Igama lami nguRithidze Mukoma. Ngihamba ikliniki yase Merrimudley eActonville.
I use Merrimudley Clinic in Actonville.
Mina my biggest challenge ngale clinic lena is that every time ase clinic sivuka ekseni kakhulu.
Inkinga yami kakhulu ngale clinic engiattendayo is that every time you have to go to the clinic, you have to wake up extremely early.
So usually ngifika lapha ngaboma 5:30 ekseni.
So I normally arrive at the clinic at about 5:30 a.m.
Kungakavulwa.
By that time, the clinic is not opened yet.
And uyahlala clinic siyahlala. And sihamba ngaboma 3-4 khani uphuma eclinic since ufike ekseni awudlanga since useclinic nje the whole day.
So by the time you arrive in the clinic around 5:30, you'd only leave at 3 in the afternoon. By that time, you have not had anything to eat.
So yoke my biggest challenge engihlangabezana nayo mawufika mawubuya eclinic ufika endlini uthola abantwana losikhathi ngihambe ngesikhiya uthola abantwana bakulinde ngaphandle.
That's the biggest problem I have, that we spend too much time in the clinic, and by the time I get home, my kids are already waiting outside. They don't have a key to enter the house.
Ngiyabonga.
Thank you.
Sanwa gama nguSimpiwe Sibonga kaShawang. Ngihamba ePalm Ridge Clinic. Engakuthandi ngaleya clinic iservice abayideliver. Shuthi mina I'm in recovery from drug kahle kahle.
I use Palm Ridge Clinic and I'm a recovering person who use drugs.
So engakuthandanga ngaleya clinic, okay, it happened ukuthi ngiyabhema. So ekubhemeni kwami, okay, I was using injection. So mangizijova angizijovanga kahle. So I had to go to the clinic because bengasazi ukuthi kwenzakalani ngami because nambe sengibona ukuthi ngiyalidinga usizo.
So as a person who uses drugs, I use injection. And there is this one time that I was trying to inject myself, but unfortunately I didn't do it properly. And then I had myself, then I had to rush to the clinic.
Okay, sengitshelile ukuthi ngiya eclinic. Okay, mangifika okay ngishaya but ngoba ngiyalidinga usizo ngizama ukuthi ngikhulume maybe ne-security ngicela kuye ngimuze ukuthi maybe angathini. Laba bebeka sharp okay mangengicamba mama.
So as I arrived at the clinic, the security guy was very friendly with me. I don't want to lie.
Because ngikwazile ukumchazisela inkinga yami naye washo ukuthi okay since kuso ngangena phakathi eclinic ngikhulume nabo lapha ngibachazela ukuthi yini inkinga yami.
So I've explained my problem to the security, and the security walked me through to the clinics so that I can go and explain to the nurses.
So mangimuzwa akhuluma security nangalendlela engithole phakathi ayifani because phakathi eclinic ngilengathola omunye usister.
So the attitude, the positive attitude which I received from a security guy was different from the one I received from the nurses inside the facility.
Because okay, naye unurse at first uzenze umuntu o-concerned about inkinga yami but afterwards uqala ukungijudge.
At the beginning, the nurse that was attending to me seemed concerned about my situation, but as we go, they started judging me.
Angibiza ngamagama ukuthi like thina as ama youngsters ama 2K yini esuke sicabanga sizifaka kuma drugs like ayikho enye into bengayenza ukuthi ngibhema ama drugs like ngiyazi injecta ngemncane kayo.
The nurse started calling me names and said that as young as I am, there is nothing better that I can do with my life than use drugs.
Ngiphathe kabi ukukhuluma iqiniso azange ngibe sharp because mina I do believe ukuthi whether wenza okubi noma okuhle but masose clinic we all need a good service delivery.
I was very hurt at this moment because as my understanding is that whether you are a bad person or you are a good person, when you go to the clinic to seek assistance, we all need to be treated the same.
Yabo.
Thank you.
Thank you. I think before we go to the recommendations, I must acknowledge the presence of Dr. Nozuko Kabayi, the acting director, Gauteng Department of Health. No, I think Umamo Refilo Motsamayi, acting chief director, health program in Gauteng. Before we go to recommendations, I think I need to make it clear upfront that our intention is not to go to facilities and identify faults. Our intention is to work with the department to improve the quality of services. Where there are faults, we raise those concerns. Where there is improvement, we are able to come up front and say, bravo, you are doing well here. And we, as Ritshidze, if we were getting written reports from the department, either at facility level, district upwards, to say on this area, this is what we have done. For sure, should we get that information, we are going to make sure that we put it in these reports. But also, before I go to recommendations, we've got a problem in South Africa in our clinics, where non-clinical staff like your security and your cleaners are interfering. When I enter into a clinic, before I meet a nurse, security is asking me, why are you here? Now, because I've got a drop, I must tell a security I've got a drop before telling the nurse. That is wrong. When I'm being admitted or consulting a nurse, uyangena cleaner, and the new cleaner is given my file to take it to the pharmacy. Cleaner is privy to my medical file. Then after Shaile time, she goes to the community and say, Yambona Lunenchebe, unengulazi is dying. That is involuntary disclosure. And that's what makes some of us to decide to disengage from care, because I spoke about dignity. And when that is happening, we feel good our dignity by edagin is the. But also, the other problem we have in South Africa, as much as we are hearing Uguti, the treasury is going to cut 1 billion, but the huge amount of the health budget does not go in buying health services and improving healthcare services. Lot of money goes to medical legal claims because of negligence, where you are wrongly diagnosed by a nurse, intentionally or unintentionally, but that nurse is overworked and overburdened because the department has frozen the post, and one nurse now is working in positions of 3 nurses, and the government is ending up paying billions and billions of rents. If we were to calculate the money our departments of health, Gauteng, Eastern Cape, all of them in total, it's more than 50 billion that they are paying for these medical legal claims. And the question is, how best can we work together to make sure we reduce this? And the only way to reduce this, firstly, is around sensitizing healthcare workers and say to them, at the end of the day, these are human beings. These people have a constitutional right. By these people coming to the health facility are not here to ask for a favor from anyone, but they are exercising their constitutional right as enshrined in Section 27 of the Constitution. At times we are made to feel, when you go to a clinic, sometimes you feel like who nurse owns this clinic, or half of his or her salary is taken to buy medicines or renovate, because the way they treat the people in those clinics is very bad. And at times, it makes people to default. But we must stress, Uguti, not all nurses are the same. There are those rotten potatoes which needs to be eliminated from the system, because if those rotten potatoes are not eliminated from the system, they are going to inoculate others. Others will be infected by that virus as well. That's why if you've got a bag of potatoes and you've got one rotten potato, you need to remove it out so that it does not affect others. One will say, but as the department, we are unable to do anything because you are reporting about faceless characters, people who do not have names. When you go to clinics, majority of the nurses, they don't put name tags so that we can be able to identify them. And when we come here, we talk about this nurse or that nurse. But I'm trying to say, this is a problem. Lastly, we were told that all people living with HIV and who are on antiretroviral treatment are registered on tier.net. But when you go to the facility, if maybe you're moving from Tembisa to Limpopo, when you get to Limpopo, they will tell you the first thing, where is your transfer letter? And in Limpopo, they are more than prepared to return you back to Gauteng to get a piece of paper. Yet you are there. And National Health Act says no one may be refused healthcare services. You are at the health facility. You do not have a transfer letter. You know your treatment. And you are told, Guti, take a bus or a taxi, go back to Gauteng, collect a letter. This is a violation of our rights. But when my file is missing as Aneleyawa, it means my medical record is missing as well, which becomes a problem to us as the users of healthcare services. But we are also aware that some of these files are not missing. They are being sold to other people, and they only change names and give to those people to apply for SASSA grant. How are we making sure as the department that the patient files are kept safe and they are not getting lost, and when they are lost, irresponsibility is made ours? Yet, Tina, we don't sleep inside the clinic, and when we walk out, we don't walk out with our files. So these are some of the problems which we think we need to work together with the department in trying to resolve them. The other thing which I forgot to mention, I also I am a board member in the Office of the Health Standards Compliance. Things that I see in those reports, both from the Office of the Health Standards Compliance as well as the Office of the Health Ombudsman, things that I see, I really ask myself, did we really got a freedom 29 years back from the white apartheid regime? Because things that our black people are doing to other black people are more than what white people did to us when we were oppressed. I will give you a typical example. This year, March, healthcare worker unions were striking, demanding an increase from the government. All clinics were closed. They were burning tires, disrupting health services, our nurses. And guess what? All of them, none of them, when they are sick, they go to these clinics and access healthcare services. They go to the private healthcare sector. It's like me cooking ukudla for everyone in this house. I'm a poto. This is delicious food. Whilst you are eating, I order Nando's. I don't eat the food that I cooked for you. How are we planning to fix the healthcare system if the ones who are providing services to us are not accessing healthcare services where we access healthcare services? This is another struggle that we need to lead as Umpagat and say, President, MECs, health officials, all of them, they must stop using private healthcare sector. We must chew together in our clinics. By doing so, we will speed up the improvement in terms of fixing the healthcare system. The reason we are treated like this is because we are black and we are poor. Because of our poverty, they know that they can afford to buy healthcare services in the private sector. That's why they are able to make appointments. One person asked me why people have to wake up as early as 4 a.m. to clinics. And I asked the person one question: why are people waking up when they go to SASSA or Home Affairs and queue there? The same problem that they experience at SASSA, Home Affairs, and other government departments is the same problem here. It's about services and how people who are meant to serve the people are speeding up the process. All of us, we've got lives. Then when we go to the facility, you expect to be attended quickly and go back home to do what you are supposed to do. But most of the times, people wake up as early as 4 a.m., wait to be served, and you leave that clinic at 4 p.m. without having anything on your stomach. These are some of the problems we as black, more especially women, black women are treated like third-class citizens in a country of their birth, in a country where they contribute in terms of making political decisions. Not long ago, this week, politicians were all over encouraging people to go and register. How many politicians are able to do door-to-door and ask us about the quality of services that we are getting? None. They only know us when we are supposed to vote. But again, this is South Africa that we fought for. The recommendations are as follows. The Gauteng Department of Health must produce an annual report on the number of healthcare workers per capita employed in each district, include the numbers of people and size of areas covered by these healthcare workers, year-on-year comparisons from at least 2021, and the cost of these posts to the government. Fill all vacancies in 2023-2024 financial year. The Department of Health should extend facility opening times as per the 2019 NDOH circular. Utilize appointment days and times to ease congestion. Ensure filing systems are maintained in an organized manner to reduce lost files. Open clinic grounds by 5 a.m. so that people can wait safely in the mornings. Ensure files are not required for facility pickup points. For people living with HIV, go directly to the pickup point to collect their ART refill. Support more people established on ART to be referred to external pickup points to reduce congestion. PEPFAR should support in filling all vacancies at PEPFAR Operation Putuma Support Facility in the short term. Provide additional staffing for all PEPFAR supported sites to extend opening hours from 5 a.m. to 7 p.m. on weekdays. Fund adequate numbers of adherence club facilitators to allow for the restart of adherence clubs. VEDS RHI should immediately do an assessment at all PEPFAR Operation Putuma support sites with waiting time over 3 hours and develop a specific plan for each facility that will bring the waiting time below 2 hours. Support the facility to organize and maintain an organized filing system. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup point to collect their ART refill. Support more people established on ART to be referred to external pickup points to reduce congestion.
Yes, Vendela. The next group of issues are on ARV collection. The revised 2023 National Adherence Guidelines note that time constraints are a challenge to many people living with HIV. They go on and say that efforts should be made to support people living with HIV with suppressed viral loads to receive extended ARV refill and or be enrolled in a repeat prescription collection strategy. Implementing this is it's vital to supporting improved long-term adherence. Ritshidze data revealed 64% of people living with HIV interviewed reported getting 3 to 6 months at refill this year in Ekurhuleni. This is a small improvement compared to 43% getting to a 3 to 6 months refill last year, and it is well below 71% in Mpumalanga, the best performing province monitored by Ritshidze, and far below the 80% of people living with HIV in 21 other PEPFAR-supported countries reported to get 3 to 6 months at refill in 2021. People living with HIV interviewed by Ritshidze, 26% collected at standard medicine dispensing, with 48% collecting at the facility pickup point and 26% using an external pickup point. Of people interviewed, 15% more using pickup points compared to last year. For those using standard medicine dispensing, 72% said they are not yet offered the option to use a pickup point. All stable people living with HIV should be offered a range of repeat prescription collection strategy option as per national adherence guidelines. Further, 15% of all people living with HIV interviewed said that they would like to collect ARVs closer to their homes if it were possible. There need to be enough pickup points to decant people into, especially linked to peri-urban clinics. In terms of adherence club, these options have been devastated since the onset of COVID-19. Most clubs have been suspended or reduced to being just pickup points. We maintain that functional adherence clubs play an important role in supporting ongoing treatment literacy and peer support to help people living with HIV stay on treatment. Importantly, in order to be effective, repeat prescription collection strategy should make ARV collection quicker, easier, and more satisfactory for people living with HIV. Yet this is too often not happening. Yet 69 of facilities monitored said that people using facility pickup points must collect files, take vitals, and see a clinician before getting their parcels. And 69% of people living with HIV said that this is the case, adding to delay at the facility. Only 45 say it takes less than 30 minutes to collect your parcel and go, as required in the National ART guidelines. Once enrolled, every effort should be made to keep people continually active. Resentment should take place at each facility consulting to understand if people living with HIV are satisfied using their pickup points or club. People living with HIV who are not satisfied or very unsatisfied should be offered a different option that better meets their needs.
We will go to recommendations, but before we go there, I need to recognize the presence Kama Murefilo Mogetle from the Department of Health, no Dr. Nozulu Mumbai, also Umamono Mbuso Msimi, Noma Mukhomotso Tinake, both from the Department of Health. The recommendations are as follows. The Department of Health should implement extended ARV refills at clinic facilities to 3 months by end February 2024 and 6 months by end September 2024. The Department of Health and VETS RHI should ensure all people living with HIV are offered a range of repeat prescription collection strategy options, and those enrolled in pickup points or clubs are active. Ensure that reassessment of pickup point option takes place at each clinical consultation to ensure people living with HIV remain satisfied with their pickup point or club. Ensure all facilities implement the 2023 Adherence Club Guidelines Standard Operation Procedures with fidelity, including ensuring facility pickup points are a one-stop, very quick ART collection, only visit under 30 minutes. No need to go to the registry or collect folders or see clinicians and etc. Ensuring re-establishment or implementation of quality adherence clubs, including group facilitation component. Increasing the number and type of external pickup points to ensure urban, peri-urban, and rural clinics have external pickup points. Ensuring people going back to clinics for their pickup point receive the script on the same day if clinically well, to ensure no unnecessary additional facility visits with effective recall system to action any abnormal results or elevated viral load. PEPFAR should monitor and hold accountable PEPFAR district support partners to implement the 2023 Adherence Guidelines Standard Operating Procedures with fidelity.
The next group of issues are on ART continuity. People living with HIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps ensure long-term adherence. But often, when people living with HIV and key population return to the clinic, they are treated badly, leading to people disengaging from care. A differentiated service approach is required for people living with HIV who re-engage in care. Some will require intensive clinical management, including advanced HIV screening and management, Some will require psychosocial support in the form of quality counseling and group support options. The majority need it to be made easier to collect treatment. These people should be offered month-to-month dispensing and should be assessed and offered access to pick-up points or adherence clubs as quickly as possible. Implementing the 2023 re-engagement clinical and adherence guidelines are vital to supporting improved long-term adherence and retention. VITS RHI should support the remaining 22% of facilities and all others in the district in training and mentoring on the changes of the new 2023 adherence SOP. Ritshidze data reveal that out of 2,095 respondents, 58% of people thought that the staff were always friendly and professional. This graph shows data across time since data collection began in the district. The district should urgently improve to ensure all people living with HIV, key population, and other public healthcare users are treated with dignity, respect, and compassion at all times. It is also important to note that Ritshidze data, Ritshidze interview takes place at the facility. People who have already disengaged from care due to poor staff attitudes, some of who would hear from in our community stories, would not have been at the facilities to interview. The best performing sites are outlined in the table, and the worst performing sites are outlined here. Out of the 63 people living with HIV who had missed appointments, only 14% said that staff were welcoming when they came back to collect their ARVs, if they had previously missed the visit. And 35% said staff counseled them on adherence. 24% said the staff still send you to the back of the queue the next time you come in. Yet, according to the National ART Guidelines and Differentiated Model of Care, SOP, people should not be sent to the back of the queue or made to wait until the end of the day to be seen. A returning patient should take up the next queue space. The guidelines specifically state that no punitive actions are allowed. People should join the queue as normal on arrival at the facility, irrespective of whether on time or late for their appointment. Punitive actions lead to people deciding not to come back again. We need to normalize late and missed appointments without penalty. People who come back despite being late have made it easier for the healthcare system. It should not be necessary. It will not be necessary to track and trace them and encourage them back into care. The person has stepped back into the facility so that the experience should be supportive as possible. While most people did not report transfer letters being a challenge, 128 people interviewed by Ritshidze had been denied access to services for not having a transfer letter across 22 facilities over the last year. While this is a low proportion of all public healthcare users interviewed in the district, given that most people interviewed are unlikely to have attempted to transfer services, it points to a larger problem regarding the communication and policies regarding transfer letters. A reminder that transfer letters are not required in the guiding principles of the re-engagement SOP, which states, if a patient comes from a different facility, it is critical that the patient be provided with treatment on the day of presentation. While referral letters are helpful, a patient cannot be required to leave the facility without treatment. 285 people interviewed by Ritshidze has been denied access to services for not having an identity document across 27 facilities over the last year. All sites should be urgently investigated. Again, it is important to note that Ritshidze interviews take place at the facilities. Therefore, people who have already disengaged from care due to challenges accessing the transfer letter or not having an identity document would not be at the facility to interview. Psychosocial support is another critical element to ensure long-term retention. Ritshidze data shows that only 65% of people living with HIV interviewed do know that psychosocial support is available. Further, a full package of psychosocial supports are not yet available at every facility. A full package of services should include provision of individualized, quality-assured counseling to patients, peer-led navigators acting as bridge between clinicians and patients, mapped network of referral services, optional support group, and food parcels. As part of psychosocial support, support groups should also be linked to each public healthcare facilities that are critical to providing counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after a treatment interruption. Treatment literacy also improves ART continuity as people understand the importance of starting and remaining on treatment effectively. Of the 1,063 people living with HIV surveyed, 84% had received a viral load test in the last year, but only 81% of those people reported that they knew their viral load. Only 75% knew that having an undetectable viral load means the treatment is working well. And only 68% knew that having an undetectable viral load means a person cannot transmit HIV. There is a major room for improvement on treatment literacy in the district. 12 facilities had perfect scores where all people living with HIV understand why an undetectable viral load is good for their health. However, other facilities performed much worse, with only 17% understanding the importance of undetectable viral load on their own health. 9 facilities had perfect scores where all people living with HIV understand why an undetectable viral load is good for ensuring you cannot transmit HIV. However, again, other facilities performed much worse, with only 12% understanding the message at Leondale Clinic. We now move to recorded stories.
I'm a patient living with HIV. It's been 3 years now. You collect medication. I'm at Meremotli Clinic. And sometimes the mapilisi abanginikeza wona are different. Sometimes they are white, sometimes they are peach, nina are aloe. And every time abangidonsa igazi ne malibuya azange bangichazela nge-CD4 count yami, nge-viral load or anything. Ngathi mangibuza ukuthi i-viral load yami ithini, bathi hayi right, sami endlini shothi treatment uyithatha kahle. Ngathi mangibuza ingakanani phezulu phansi, si baningi abantu bakhona la mina siba attend namhlanje. So nama ngisabuza next, ngifila ngathi bayangifeila. Because ayikho into bang-educator ngayo, akuna ikhona ilo ama-groups abantu abasha, but most of the time kuya nge-data bakunikeza yona ukuthi uza ngelangeli, so mawufikile yeah akhona ama-charts aplakiwe ne, but angaze ngayobona lawo ma-groups we-youth kuthiwa nayi namhlanje leyo group leyo nto yakhona yayenzeka namhlanje wathi angaze ngayibona. Aza angikhumbuli bangireferela kulawo ma-support group lawo we-youth or anything. Yeah, I do wish ukuthi nami ngibe khona kulawo ma-group lawo ngizothola i-experience, ngifunde okuningi kubo, mhlambe nami ngifundise ngaloko engikwaziyo, si-educatane.
Ngola eWhiteville, ngicommunity, ngithatha i-treatment ye-HIV positive. Ama-challenges engiyahlangabezana nawo eclinic ukungaphatheki kahle, nalo kuhlalisa isikhathi singanakwa bayalena ne-attitude bangithethisa, zange bakwazi ukukhuluma nami kahle. So after that ngatshela ubhuti wami ukuthi angisayi eclinic ngiphatheke kabi, saba le attitude yabo. Abanye bagcina ba-defaulta ngendaba ye-attitude. Lokuthethiswa khulunywa nathi ngathi sabantu siyingane ezincane, so ugcina end up so usabuke eclinic uhlale, yayibona. Enye into mele sinikwe isikhathi, like babakunika appointment mele bakunike nesikhathi ukuthi ufika nini, because ufika lapha ngabo-6 uyohamba later ntambama, yabo uthi buhlungu kwesikhathi awuphethanga nemali yokudla awunayo, and kusavaliwe neclinic kuvulwa nini ngo-8 and sima kuphi ngaphandle.
Ngisacela ukuthi bangisize mina ngidla ama-ARV. Organization cela ukuthi angikhaphe ngiyolanda amapilisi eclinic remote clinic ngeke ngahamba ngaye Natali last year ngahlala 6 months ngaka eclinic mangibuya bangitshela ukuthi ngihambe ngiyofuna ilo transfer eNatal banginika nje awaleyo 3 days leyo 3 days only bathetha lethi kuza clinic engihamba le emakhaya akaze bangiphi inkinga.
Ngihamba eclinic yaseLthabo. Impatho yakhona i-right sometimes. Amanesi mawa right nje avuke ngo-right. Sometimes iba nokulekha somehow. So since when ngiphuza amapilisi we-HIV nginokudefaulter thokuthi akunakudla la endlini noma uthi ufuna usizo eclinic sometimes akutshela ukuthi i-social worker alikho uthi ubuza some of nurses ukuthi ngoba sifuna ukudla abazosipha kona like njengoba sinokulekha some ngokudla sometimes bakutshela ukuthi ikakhulu bapha laba abaphuza amapilisi e-TB. What about thina esidefaultayo emapilisini? Ande ngekukokoteka makhelwane makhe ngicela ungiphe nje ithusi la ukuthi ngiphuze ipilisi so uzazisa istatus sakho sonke everywhere and which is wrong.
Ngithatha i-treatment ye-HIV eWinnie Mandela Clinic. Uma ngabe ngifika ekliniki kuyenzeka ube number 5 or number 6 kodwa ke ugcine se uhamba la se ungene ngishabo ma 51 ugcine susemuva angazi nami ukuthi kanjani. So ekliniki bakwenzela iappointment uma ngabe bakwenzela appointment wangafika ngalelo langa uma ngabe ubuya ngakusasa bayakunika inamba kodwa uba semuva bakusiza ekugcineni. Nami ngimise i-appointment bekufanele ngifike izolo idate yami ibizolo uma ngifika namhlanje kwathiwa bazongisiza ekugcineni. Hayi ngiphathi kahle because nami ngivuke njengabantu bonke.
Mina ngihlala la hospital view and then ngithatha i-treatment la e-Evan clinic. Bona yes bayatry ukuthi singabi crowded la clinic ngoba angizi njalo because manje ngizile bazongicheck ukuthi ngi-right ngithola i-treatment yami and then I know my next date ngizohamba ngiyocollector e-chemist. Igazi ngilithathile this year ngo-March mara azange baze bangichazele ukuthi ama-results wami ami kanjani. Yes mina ngawafunda ane ngiwa-understande ngale ndlela yami but yena as i-healthcare worker kumele angichazele ukuthi mayiso isho ukuthini, i-viral load yakho kanjani, CD4 count yakho kanjani, uphuza kahle amaphilisi. Mina I have to figure out for myself or mhlawumbe ngibuze a friend yami owunesi ukuthi ama-results aso asho ukuthini then khathi azongichazela ukuthi asho ukuthini.
Nikile Mothembisa Health Clinic Soden. Kinkile transfer from Free State. To be honest, azange thola treatment sharp. So then kile ka ba fa ID ya ka ba fa le transfer ba ntshwetsa gore no ke tlamile ke batle ba batla proof of resident. Ka ba jwetsa ke re no ke dula hole and so then nkesi and le lot ya ka hayo. So then ba re hona ba ke se khone ho nthusa without proof of resident. Azange antula sharp cause by that time azange thola di treatment yakhe. The other day ka tla le proof of resident ba mpulela file tlamile ba nke body testing in kaofela. So then sister o mone ona le busy o mong and transfer ho another sister ne o mo antsetsa gore ena ke se khone ho nthusa. So then yena ke ngwana motho. So then azang la ntula sharp lentsile la haila gore yena ke ngwana motho thuso. By that time azang ka thola thuso ke le ka boela hae ntlong ke sanka madi ke setsa pap smear ya ina nna ka ka etsa pap smear la nka madi azang until be ke reka di pills mo clicks azanga khutlela clinic and ke na le fear even today ke tshaba ho ya clinic ka ona treatment eo ya bona fela. Treatment e ke nwang ke antiretroviral treatment. Yeah. Ne tlamehile ke di nke mo Thembisa Health. Yeah, se bile ke di reka no. Attitude tse e ya bona is by change parce que ba jaja motho like ba re treat equal. So then le e ke batla gore ba change ke yo ya transfer yo mpela e serious ya gore be re batle di proof of resident mare tshwere di transfer le ID ya ha holo nka thabela thuso ho tsetsa mahala cause ke a spend and nini dina lo fela pele ho nako sometimes motho a default otla nini o default 5 days 4 days o tla bona di fela le nni ha ke na chalete let's say yes.
We now move to community members who have joined us today.
Sanmonani, mina Prudence. Greetings. My name is Prudence. Oh, took my story. Oh. Mina ngiyengaba ne crisis eli Tabong Whiteville. I attend the Tabong clinic in Whiteville. That's where I got a problem. So mangiyofuna ifile. Angitshela ukuthi ifile lami limisplaceekile kanjani angazi ngoba nalo muntu othatha ama file uye osibizayo makazo basizongena ku surgery. So when I went to Wadeville Clinic, I was told that my file is missing, they cannot find it. I did not understand why because I never touched my file. The person that collects our cards then is the one called us to go to the consulting rooms. So mase bangibiza lapha ku reception bathi ifile lami ligcine kubani ngithi kulo bhuti lo thatha wona ama file ukuthi lahleka kanjani angazi. They called me at the reception and asked me who did I last leave my file with. I said I do not know, it's by the guy who always collects the file. So i-report yami yonke kushuthi inyamalale ne-file and I had to ukuthi ngiqalele back to square one ngiyothatha igazi ngiqalele kabusha ukuthatha treatment. In that instance, I lost all my medical records. Then I had to be started afresh. They had to withdraw blood and they had to reinitiate me on treatment. So next month nge-13 ngiyabuyela futhi kumele ngiyothatha igazi. And it means that I have to be attending the clinic again, like next month on the 13th, I'll have to go back for bloods. So okuningi ngizabona kaphambili ukuthi kwenzakalani angazi ngizabona nami ukuthi kwenzakalani ngiyabona. Then I do not know what would happen from there. I'll see when I arrive at the clinic.
Sanmanani,
Greetings.
Igama lami nguThembi Masilela. Ngihamba eMary Moodley eActonville.
I attend Mary Moodley Clinic in Actonville.
Yeah, inkinga yami ukuthi mabakuthatha igazi abazi bazosirepotela ukuthi i-CD count yakho ithini ne viral load.
My problem is that I do withdraw blood in the facility for my viral load, but I never get my results explained to me.
Yes. Mobuza nge-viral load abakutsheli next. And like mobuza ama-question amaningi, loyo sister loyo mobuyela next time, uba ne-attitude for wena. So like wena ukhuluma kakhulu, uwazi kakhulu kundlula bona.
So if it happens that I do ask some questions about my CD4 count and the viral load, they do not give me any information. And the next time, because I've asked questions when I go to the clinic, the nurse will then give me attitude and tell me that I know too much and I ask too many questions.
So besicela ukuthi nje abo sister bangasijudge sisebenzisane nabo basebenzisane nathi ngoba nathi sabantu sinama feelings and ezinye izinto dirutlisa botlhoko ka mogare.
My plea to the clinic staff for the nurses is that they need to work together with us as we also cooperate, because some of the words that they alter to us do hurt us.
Ngiyabonga.
Thank you.
Sanibonani.
Greetings.
Igama lami nguZandile wakaManganyi. Early this year ngiyengaya eLithabong ekliniki
I attend Lithabong Clinic
for HIV treatment.
for my HIV
Uqalela
treatment.
phansi ngoba ngiyenga defaulter ngendaba ye family matters.
I had to be reinitiated because I had defaulted due to family problems.
So ngesikhathi ngiya ekliniki bangitesta again ba confirm i-status sami and my results wami mabuya back ukuthi ngi-positive and bengicela banginikeza i-treatment ne-blood sample bathatha negazi la ne-virus load yami and when lesikhathi ngibuyela futhi bangithathe ikliniki after 3 months the umphathi wekliniki phama results wami and banginikeza abazange bangitshela ama-results banginikeza nje amapilisi kuphela ngaphuma ngahamba so bangangitshelanga ukuthi kwenzakalani nge-virus load nayo yonke le nto leyo.
So when I went back to the clinic, indeed I did get reinitiated. They did viral load test. And then they told me to come back in 3 months. When I went back in 3 months, they did take other blood, but I never got results on any explanation as to what is happening to my results.
So ngifila kanjalo ukuthi ngiyengafila ngenye indlela ukuthi ngathi ngiya undermine because akangitshelanga nekusuvele wathatha nje igazi wanginika amapilisi wanginika idata angazange ngazise next.
So I did feel as if I was being undermined at the facility because the nurse just gave me medication, gave me a new date after taking viral load test.
Sanibonani.
Greetings.
Bengihamba Mary Moodley Clinic.
I used to attend Mary Moodley Clinic
for 4 years.
For 4 years, for the past 4 years.
Enye nurse eyaseMary Moodley yangibiza yathi wena ufunani la. Ngamtshela ukuthi ama-clinic ayafana wonke angithi. So iMary Moodley ingiphatha kahle. So ngihamba yona wathi no wena go back Whiteville eLithabong. Mangifika eLithabong yo athola ubunzima obukhulu.
So as I was attending Wadeville Clinic, this day when I went for my appointment, one of the nurses told me, what am I doing in Wadeville? Because I'm supposed to attend Lithabong Clinic. I did explain that I prefer to use Wadeville Clinic, Mary Moodley Clinic, because I feel comfortable there.
So manya eLithabong, oh, mangifika khona, ay. Nesi yangineze attitude enzima kanjani yo ngathwala ubunzima makumele ukuthi angineze treatment yami bakhudula inyawo or understand ukuthi kwenzakalani so ngaqola ukuthi mangihlale ngingasayi kuyothatha treatment yami ngawa defaulter ngaphinda ngahlala phansi ngazibuza ngathi no impilo yami le mangibuyele go back ngiyolanda treatment yami.
Okay, after I was turned away from Mary Moodley, I then was referred to Lithabong Clinic, where I went to collect the treatment, my treatment. However, the services at Lithabong was not fine for me, as the nurses were taking their time, they were just having attitude. I did not understand what was happening in the facility, which resulted to me defaulting my medication again. I stayed without taking treatment for some time, and after several months, I spoke to myself and told myself, this is my life, let me go back to the clinic and take my ARVs.
I'm a resident in Whiteville.
I'm from Whiteville.
I
attend Lithabong Clinic.
I treatment in Lithabong Clinic. So I have found out after 5 years that I'm HIV positive. I started the clinic. I'm still a student at Ekurhuleni. I went to the clinic with the uniform wearing. They always say, fast, I stood there, because I need to go back and you test on 12.
By the time I went to the facility, I was a student, I was on my uniform. My understanding was that when you get to the facility and you are a student and I had exams to write, I thought maybe the services will be quicker for me.
So on my appointment date, I went to the clinic. Go appointment card yam, they didn't write the time. Legus meaning arriving at the clinic. So, mang attender. I'm telling you, nurse, I need to go back to the Ekurhuleni. Nyopala 12. What I thinking I am late. When I was a treatment, I could do no okula now.
So as I was initiated on treatment in the facility, I was then given a date. I was not given time to go to the facility. So I went back to the clinic on the date that I was given. And as time went by, since I had exam to write, I approached the nurse and told the nurse that I need to go because I'm going to write exams. And she told me that this is my life, it's not hers. So I need to choose what I need to do.
So, Mangzongena, consultation room, it's my turn now to get in.
By the time it was my turn to get into the consultation room,
I don't know who's or nurse because she gave me a 1 month treatment.
by the time I went into the consultation room, I don't know if the nurse already had an attitude against me because I was panicking and I was asking too many questions. Then the nurse just gave me 1 month treatment without any explanation.
So I next month landing in treatment, knowing very well I'm a student. So I can't just love because I need to attend because already we're going my exam times.
So after she gave me the 1 month treatment, she said to me, you'll have to come back next month again to collect your treatment. This was stressful for me, knowing that I'm a student, I need to go back to school, and I can't always skip school because it was exam time.
So I got 1 month treatment still on my appointment card. I this card so only bala date. So I ngimbuza how sister wangangibhaleli isikhathi athi uzofika ekseni njengalabo abanye abafolayo ngo5 ngaphandle.
So on my appointment card, I only had a date written on it, and I asked the nurse, can you please give me time when I must get to the clinic? And she said to me, you'll come in the morning just like everybody else that comes in the morning.
Sanbonani.
Greetings.
Mina ngihamba e-Andries eLangaville clinic.
I attend Andres Clinic in Langaville.
Inkinga yami ngokuqala ne.
My problem.
Mawufika eclinic, obvious vele kugcwele, una ufika ekseni kumele ufole njengabanye abantu vele sijwayele futhi asana nenkinga.
So as our clinic is always full, we have to arrive there early in the morning with a lot of other people. We all have to queue outside, and this has become a norm to us.
Uzofola iline bese mawuya lapha reception ubanikeza le card lakho ngisho kumele bakhiphe le file. Mawumnika lo sisi lo khipha ama file uyovela athi kuwehlala phansi.
So as we continue queuing until your time arrives to go to the reception to hand over your card. And as you move to the reception to hand over the card, the lady at the reception will just tell you, please sit down.
Mawuhlala phansi kanjalo, okay, awalande. Maqeda lapho sizohlala. Uzayilinda ifile uze uthi shu. Baphume or bayetiyeni or bayenzani badla amagwinya babhizi bayaxoxa. Ngasikhathi mhlambe nawe uphume ekseni. Medication, medication am ngiphuza ekseni. And angikwazi ukuyiphuza ngingakahle ngoba iyahwayana kokuqala.
So what then happens after we've handed over our card is that the reception people will take our cards. By then, we would wait for long, our cards will not come back. They'll be busy chatting and having their breakfast whilst we are sitting there. Like myself, I take my treatment in the morning and I cannot take my treatment on an empty stomach.
Hayi mababuya ke basinikela ama file mabaqeda uzongena ku sister. Mawungena ku sister, sister so folile athi kuwe mele uyodonsa igazi. Phela thina abanye asaza ngisho sibasha. Khani sifika like khana ngi HIV positive na 6 months ngitholile ukuthi I'm positive.
So as a newly diagnosed patient, you'll then queue and then it's your time to get into the consultation room and the nurse will then tell you you're not supposed to be here, you're supposed to go and do your viral loads.
Ufole futhi enye line ye-viral load ngoba awafana ama-line. Ufola la, mawusuka la, makube akusilanga la, maybe ngisho ufole la. Bese mawusuka i-line yokuthatha igazi enye i-line and icabanga ngifole la. Ngifolile ngaze ngafika ku-sister, u-sister kujikisa athi mele uyele uyothatha igazi enye i-line futhi ilanga liyachubeka uzovele uphume intambama ngapha u-drowsy awudlanga yonke into nje uyayibona. So nje sibuthwele ubunzima bafethu. Asibuthwele but sizoyenza njani ngoba sifuna i-medication sifuna ukuba right.
So it is very difficult for us people who are taking treatment because after you've been told that you must be on this queue and then you are told again you must go and join another queue which is also very long, you'll end up spending the whole day in the facility. This is very difficult for us, but what can we do as people because we do need treatment at the end of the day.
Dumelang.
Greetings.
Lebitso la ka ke Dimakatso Mokoena. Ke tswa ko Vosloorus ko polyclinic.
I use polyclinic in Vosloorus.
Re na le bothata ko poly like nna ke motho e leng gore ke tshwara di-piece job. So ha ke tshwara di-piece job ke na le ho ya maybe ko poly ka bo mathu ha ke chaisitse or bo 3 bao nako ke kgonang ho e thola. So ha ke fitla ko tleliniking ha ke kena ka gate security le njwetsa hore ho late ke a mjwetsa ke ga nna ke tswa mosebetsing a rona hai noma o ka kena ka molanya ke batle ba o thusi. So nna ke ikenele he ka hare ha ke kena ka hare ke jwetsa bo sister rona ke tswa ko mosebetsing khona ke chaisa nochi ba rona ke tle ka osane bona ba ya chaisa manje ka 3. So ke tsamaye.
Okay, so it is very difficult for us. As myself, I do piece jobs. So I'll first go to do my piece job when it's my date for an appointment, and I'll go back to the clinic around 2. As I arrive at the clinic in Poly, the security will tell me that the clinic is already closed. Even if you get inside, the nurses will not help you. I will force myself to go inside and speak to the nurses, and the nurses will then tell me they cannot assist me as the clinic has already closed.
So ba re hona ke khutle the following day ke tsuwe o seng ke ye ke ngamele hore ke ye vele because tlamile ke ye ke lo nka treatment ya ka.
Then I was told I have to come back tomorrow in the morning for me to get my treatment. So I went there the following day as instructed.
So ha ke fitla ko tleliniking ke tsuwe o seng ke ko tleliniki ha ke fitla ko tleliniking ba rona ke emele ka side because na date ya ka ne le maobane ba tla qena ka nna ho kwala tleliniki.
So when I went back to the clinic the following day, I woke up early in the morning to go to the clinic as instructed. But to my surprise in my arrival, they told me that I need to step aside. They will attend me last since I missed my date. My date was yesterday.
And hape re na le bothata nna ke na le 9 years ke le positive ke nwa di-ARVs. Since ke dinwa from go poly.
I've been living with HIV for the past 9 years and I've been on ARVs from polyclinic.
So ha ona le tshintshwe le lengwe le a etsahala. Sometimes o thole hore ho ya bata. Tlamile re eme ko ntle ko strateng. Tleliniki e bulwa ka 8 o'clock. So tleliniki ha e bulwa ka 8 o'clock. Sometimes o thole hore maybe pula ya fatsa. Ha re bua le security re jwetsa go security ho ya bata ka mo ka ntla ona pleke le hore maybe re ka kena ko yona hore at least le gona re be home. A re jwetse hore yena ha re na pleke gone e leng hore maybe re tlo ema ko yona tlamile re eme hona mo until bo sister be ba fihle.
So what happens in polyclinics is I've been attending this facility for the past 9 years is that we wait outside in the facility and the facility will only open at 8. So should it happen that it rains or it's cold in the morning, we then ask the security to please open for us, and the security will tell us that there's no place inside. So we need to wait outside whether it's raining or it's cold.
So when ne re kopa le tshintso di sister tsona di right for rona, otherwise ha ba yo root for rona. Batho ba leng root for rona ke di security ene di bua le rona ka re di bua le bana ba banyane. Sometimes a go bua le ena a jutsa he wena suka la le date le accident date yako o funa ngoba accident date yako ha ro am explain again ke taba tse ding again. So ne re kopa thuso ya hore at least ka wa ko polyclinic re thole le tjhentjho. Next year ke etsa 10 years ke le HIV positive. Mara ha ona ntho e leng hore ya change.
So next year I'll be 10 years living with HIV. So the challenge in polyclinic is the security. The nurses are friendly and they treat us right. The problem is the security guard. They treat us anyhow and they speak to us as if we are kids. There's never been any improvement in polyclinic, and we'd request that something has been done regarding this facility. Thank you.
Dumela.
Greetings.
Ka lebitso ke lebohang ke tsamaya ko polyclinic.
I also attend polyclinic.
Ho etsahetse last year ka April ka kula.
Sometime last year in April, I got sick.
Ka tsamaya ka sepetlele ba fihla sepetlele ne ke sa tshwara treatment.
So I was admitted at the hospital, but unfortunately I didn't have my treatment with
Ha ke
me.
fihla o fumantsha hore ba re ba yang admit ke tlo robala sepetlele.
Then I was admitted in the hospital.
Ka robala sepetlele ntho ya pele ke leng ka fihla ka e tjho ho di nurse tse ko ho teng e ke dulang ko yona. Ke fihlile ka ba jwetsa hore nna treatment e ke enwang ke nwa di ke nwa di ARVs. So a ka di tshwara ke na tsona ke kopa ba mfe dipidisi ke kgone hore at least ke se ke ka default.
So the first thing I did, as they told me I was going to be admitted in the hospital, is to explain to the nurses that I am on ARVs and currently I do not have them with me.
Ha ke fihla ka mole ba re ho nna pidisi tse ke di nwang bona ha bana tsona. So pidisi tse ba tlo mfang yona ba tlo mfa pidisi A1 e le hore ke nwa tse 3.
So they told me that the medicine that I'm taking, the ARVs that I'm taking, they do not have because I take 3 tablets. So they told me that they'll give me 1 pill because they do not have the medication.
Ha o fihla doctor ba mo jwetse ba mfe treatment e ya pidisi A1 ke enwe. Ke dutse sepetlele from ka April till end of May. Ka May ke tswe sepetlele.
So I was hospitalized from end of April to end of May. By that time, as they had explained to the doctor, I was being given a 1 pill.
Ke tswe ke sepetlele ka June ke nka madi ke tsamaye ke nke madi ke fihle ke jwetse ngwanyana o re fang dipidisi ka kwa ko poly ya gale. Ba re fang treatment ke mo jwetse hore ba ntšhintšhile dipidisi ko sepetlele ba nneile lengolo kile. Ba itse le se ka tlhotse le nneletsa dipidisi tsele tse neng le mfa tsona ke nwe pidisi A1.
So when I was discharged from the hospital, around June, it was my appointment at the facility, at the clinic. I went back to the clinic with the letter that I got from the hospital that was explaining that my ARVs were changed to the 1 pill.
Ka December ha ke ya hape ngwanana o am till December. Ka December ne ke tlamehile ke lo bona sister ke fihla a ho nna ai le bongcono go tsamaya go iso sister because go fa treatment e tlamehile a bone lengolo le le ka mo ka fileng ya hao a tlo kgona hore at least a ngole ko fileng ya hao hore o tšhintšhiwe treatment sepetlele.
So the nurse that attended to me around June did give me the medication as prescribed by the doctor from the hospital. My next appointment was on December. When I went back there, the nurse said, we need to go and see the matron so that it can be written on the file that you are now taking the TLD.
A ke fihla ho yena ke mo fa lengolo a re yena a re ho nna ke mo jwetsa hore dipidisi tse baneng ba mfa tsona tse 3 di nsebedisa mala and pelo ya ka e ba ntsho and di nchintsha color ya skin and njoba di nchintsha color ya skin le weight a ke gain weight and since ke nkile madi ka June o mongwanyana o ba re fang dipidisi o itse di results tsa ka di right a di tshwanele ka nako e ne ke nwa tse 3 a re ho nna yena nna a ke patient ya sepetlele ke patient ya bona so a ke khone ho nka lengolo le ba mfile lona sepetlele ke tle lona mo clinicing ke re bona ba ntšhitše treatment bona ba tlo mfa treatment e bona ba nentse ba mfa yona a nke pampiri e la sepetlele a e tabole a e kenya dustbin.
So as myself and the nurse reached to the matron, then I had to explain that the treatment that I was taking, which is 3 tablets before I was admitted, was not treating me well. My skin was getting dark. I was getting diarrhea often, and I was losing too much weight. So I had a letter that the doctor has changed my treatment to TLD. But the matron then said to me that I am not the patient of the hospital, I'm the patient at that clinic, and she's gonna give me the treatment that she had initially prescribed for me and will not give me the treatment that the doctor has prescribed for me. And then she tore away the paper that I came with from the hospital.
Since December last year, azang sapita khutela kliniki, azang sapita ke lo batla dipidisi, azang ka tsama ke tsama house to house. Ke kopa dipidisi o ba mfe dipidisi khona o kene because tsele dipidisi tse ba mfang tsona a di right phone. Since gcina last year at clinic until no work so ke.
So during December, when this incident happened with the matron, I never went back to the clinic because they gave me the 3 pills which do not go well with me. I have to live by asking treatment from neighbors. I have to go house to house asking treatment because I cannot take the 3 pills that they gave me in the facility. And I never went back to the facility.
Before you come in, Mhlekazi. Before you come in, Mhlekazi. History will judge us harshly apart if this meeting is going to end without us doing anything about this. The people that are missing from care, that which the department is looking for, are here. And I'm sure all of us, we can hear what makes the majority of people living with HIV to decide not to go to clinics again. Because of the bad attitude we get in some of the hospitals. We do not want to die in silence, but we want to die with our dignity intact. Instead of our dignity being dragged into a mud in these health facilities, some of us decide not to go to clinics. I humbly ask Usisi Lo tonight, she must sleep with peace and peacefully, and other people who are here, knowing it very well that she's got her ARVs, and if possible, take her to that facility, and if possible, you deal with that nurse. Because it is not only Usisi. How many people like Usisi who decided not to take a treatment because of one individual who knows that the government is paying for her to go to a private hospital, yet the poor black woman is made to suffer? Please, I'm asking that we make sure that today Usisi gets a treatment. You may proceed, my brother. Thank you.
Thank you, Jess.
Lono kulbayo lihlono lo sehle.
Okay.
Siphethe ubunzima emakliniki ngempela.
It is-
Uzwa itori lana.
It is difficult for us in our clinics.
Mangibhekile zonke le itori kuyiciniso into esizibonayo emakliniki.
Everything that has been said here so far, it's true, and what is happening in our clinics.
Mina ngi-attende i-North Mid Clinic eBinoni.
I attended North Mid Clinic in Benoni.
Ngasho ngithi khona ngakuthola usizo mangifika.
At first, when I arrived, I did get assistance.
Kodwa inkinga yokucala engingaba nayo indaba yesikhathi.
The problem that I had initially with the facility is time.
Ukufika la eclinic la bengikhona. Ukufika eclinic la bengikhona.
Arriving at the clinic where I was,
Bokungithatha 2 hours ukufika.
so it takes me 2 hours to, where you working?
Ukufika khona.
From my house to the clinic.
Yeah, ngoba ngizothatha itaxi and then I will walk maybe an hour ukuthi ngifike lapha.
So from home, I'll take a taxi, and then where the taxi drops me, I'll have to walk for about 1 hour to the
The
clinic.
reason being ukuthi ngiye khona there's a family member bekasebenza lapho angiloko angikhuthaza ukuthi ize clinic and all that.
So the reason my choice of this facility is that there was a family member that was working in the facility that had encouraged me to come to the clinic.
Ngempela I attended the clinic nga diagnosed lapho North Mid Clinic.
Then I did attend the clinic in North Mist. That's where I got diagnosed.
So but besinayo inkinga yokuthi manje or asazi shop staff or wenzakalani. So ungajaja wena ngithatha 2 hours ukufika lapha ya. But ngizophuma ngo3 mhlambe ngifike lapha ngo7:30. So you now ungacounta ukuthi ngivuke ngobani and then le 2 hours engihambile ukufika lapha.
So I really do not know what is the problem with this facility, because I'll arrive at the facility after traveling for 2 hours, and I'll arrive at around 7:30, but I'll only leave at around 3
So
p.m.
bese no complain amasingama patient but phela sibuye siduduzane uthola ukuthi nabo mama abadala bathi hayi ungakhali mntanami impilo yakho le.
So as we are seated there with the patient, we'll normally complain amongst ourselves, but the elder people will then tell us and encourage us that we should not give up, because this is our lives.
So kwabangcono bangireferela etleaks.
And then it got better as they referred me to clicks.
Okay, treatment time ngithatha etleaks convenient ngifika in an hour ngilithathi lapho and it's close kimi vele yabo etleaks kusebinono.
So then I got referred to clicks, which is very convenient for me because it's very close in Benoni, next to where I reside.
So this year I went there, I think June,
So-
if I'm not mistaken. Ukuthi ngiyothatha igazi.
This year around June,
Appointment,
it was my appointment date and I had to do viral loads.
So mangifika laphayana, okay fine, I sesijwayele vele ukuthi ama files mhlambe soyithola ifile yakho noma ngo9 or to 9 whatever time oyitholile. Le bekuseyinto evele sesijwayele clinic.
So what is happening now in the facility is that we'll have to wait for your file, and we already know that it's going to take time for you to get the file. You can even get your file like around 9 or after 9.
So usually bekune container ngaphandle. So they will take us to this container. Noma besingafithi sonke but baloku banibiza ngalo ukuthi okay sicela i10 easy or sicela a certain amount ize ngapha.
So in this facility, there's a container inside the facility where they will call us in. However, the container is not that big, so they will call us 10 by 10.
But this time around, mangifika laphayana lo sisi wongiphe file athi kimi buti hambo uyabona labantu abahleli laphaya.
But this time when I arrived at the facility, the situation was different. They told me to join a different queue.
So laphana kungaphandle vele.
Then there it's outside.
So banibiza vele ukuthi chronic this side.
So now the problem there is that it is outside where everybody can see us, and the nurses will be calling chronic people, please come this side.
Sicela mental health this side.
And then they will separate us according to our
Just
medical
imagine sihleli
condition.
ngaphandle uyezwa ukuthi ukushisa kanjani.
Can we hear how hot it is?
Mabangathatha le tende leli balisuse leli.
And if they could remove this tent right
I
now,
wanna besingakhona ukubekezela la.
I'm asking myself if we'd be able to be sitting
I
like
had
we
to
are
sit
sitting
there
now.
until 3:30 elangeni.
But that's the condition I myself was sitting in the sun until 3:30.
At last makangibona usister.
When it was my time to enter the consulting
Hayi
room,
ngempela angithathe igazi.
and then they did a viral load test.
Hayi fine. Then I received a phone call ukuthi no Hlonolo sicela ubuye eclinic.
Then I received a phone call a few days later, so that telling me that I must come back to the
Mangibuya,
clinic.
same thing happened futhi.
When I got back, the same
Mangifika
thing.
kuya athi yazini asazi kwenzakaleni ngama results wakho but la awunama results. So ngizocela ukuthatha igazi futhi.
The nurse then told me, we don't know what happened to the
Ngaphuma
blood
lapha,
sample
kora
that we
pa-
took from you, but we had to withdraw blood from you
Ngaphuma
again.
lapha 4:45.
I then left the facility again, 3:45.
Now ungayicabanga nje leyo nto ukuthi ifrustration ongaba nayo. So as a result wangipha futhi appointment ukuthi kumele ngibuye futhi.
Then I was then given another appointment after
Ngicela
the
ukubuza ukuthi wena
frustration
ungabuyela lapho
situation.
na.
So I want to ask in the house, if it
Sorry
was
ukuthatha
you,
isikhathi,
would you
for
go
sure
back to
ngithatha
that
isikhathi
facility?
eside, but lento le ibhlungu. Yabona, so yizo izinto esihlangana beza nazo emakliniki. And ukukhatha short indaba yabantu abadala. Nabantu abadala abaphathwa kahle. Uthola usiphuma naye ugogo since afole since 6 o'clock and bavuka phela bogogo. But uyophuma nami ngo 3:30.
So the same situation that is happening to us is also happening to
So
elder
ziningi
people.
engazichaza nethi isikhathi sengihlonipha isikhathi.
There are a lot of things that I can say as challenges at the clinic that I use, but I'll be short to try and respect time.
Ngiyabonga.
Thank you.
Sanibonani.
Greetings.
Ngu-Bridget Gatebe ngithatha i-treatment remotely.
I use my remotely clinic.
Ngeyi-13 zaka-September ngamisa i-date yami.
So on the 13th of September, I had missed my date.
So mangibuyela following day ngithi ngikhipha ikhadi lami le-appointment. Athi sister bokumele ngabe uze izolo. Ngithi ngiya-explaina kusister, sister athi ayi cela umelele ujike socibanga ungangi-explaineli next. Okay ngibuyele emuva ngiyohlala phansi.
So as I missed my appointment on the 13th of September, I then went to the facility the following day. As they were collecting my card, the nurse said to me, "You had missed your appointment. Your appointment was yesterday." And as I was trying to explain the reason why I could not come to the facility yesterday, the nurse then dismissed me and said, "Just go back to the queue. You'll be seen last." Then I indeed went at the back of the queue.
Ngihlale ke ekliniki. Awusambi isikhathi sami isikhathi masokushaya bo-2.
Then I waited at the facility until around 2.
Ngitshela ipartner yami ngithi ayi mina ngiyahamba kulini ngihleli la.
Then I told my partner that I'm leaving because I've been waiting here for
Ipartner
too
yami
long.
ithi hayi mana sibekezele bazokunceda ekugcineni.
Then my partner encouraged me that we should wait. I will get assistant.
Ngihlale.
Then I
Vele bagcine
waited.
ngami ngiphuma ekliniki ngabo 4:45.
Indeed, I was the last person to be attended to in the clinic. I then left the clinic on that day at 16:45.
The way siphatheka ngakhona emakliniki.
That's the treatment that we
Asiphatheki
receive in
kahle.
our clinics, which does not sit well with us.
Yabo.
Thank you.
Sanibonani.
Greetings.
Mina ngambi treatment eWhiteville eLithabong.
I attend Whiteville Clinic in Lethabong.
Since ngaqala zange ngibe ne problem
Since I started attending the clinic, I never had a problem
until whereby upartner wami waba ne problem yokukhohlela.
until my partner has a problem where my partner was coughing.
So ngamkhuthaza ukuthi hayi mfazi aseclinic uyotesta.
Then I encouraged my partner for her to go to the clinic so that she can also get tested.
Ya ngoba ngibona ukuthi bese kuphela i2 weeks aloka khohlela.
It was over 2 weeks since she has started coughing.
Yeah, so since basifundisa ukuthi mawungakhohlela more than 2 weeks mele na kanjani uyotesta. Something is definitely wrong.
Yes, this was based on the fact that since I got information that if you are coughing for more than 2 weeks, you must come to the clinic to get tested because it means something was not right.
Kwatholakala ukuthi ngempela uyatesta. Ama results abuyathi une TB.
And then my partner indeed did get tested and the results came back confirming that she had TB.
So waqala i-treatment immediately.
Then she was immediately initiated on treatment.
So because I was aware ukuthi mawudla i-treatment ye-TB ungasebenzi. Kuya unelungelo lokucela i-assistant.
So as I had a little bit of information to say if you are on TB treatment, you have a right to ask for social, psychosocial support.
Okay, masithi sikhuluma no sister lo ophethe vele abantu abaphethwe HIV. Sathola ukuthi kunomphathi kulelo office.
So as we approached the nurse that was working on the side of TB patient, we also find out there was somebody in charge in that area.
So mina ngokubona umphathi ngajabula ukuthi at least now umphathi sizoluthola uncedo.
So I was excited when I learned that there is a manager in that area and would get assistant, I thought.
Yeah, ngithengisa explainela usister ukuthi sicela usizo kanjani. Usister ngakangiphenduli kwabe kuphendula umphathi.
As we were trying to explain to the nurse what kind of assistant we were looking for, before the sister in question could respond, the manager responded.
And umphathi the way aphendule ngakhona azange aphendule kahle ma. Aphendula ngenhlamba. Asithuka instead.
The matron, instead of responding to us, she then altered vulgar and insults.
Ya inhlamba yakhona azange bemnandi mangoba wabiza igama elikhulu lokuthi niyahlupha nihlelela ukulalana.
So the matron said to us that we are problematic, all we know is just to have sex.
Ya bese manigula
Then when we are not well or we are ill,
nizocela usizo lemali zethu. Le mali nizithola kusasa imali abazidonsa kithi.
and then by the time you get sick, you'll then come to the clinic to ask assistant for our monies, because the money is also the ones you guys are getting from SASSA also comes from my salary. That's what the sister said.
Ya kwaphela kanjalo saphuma sidanile kulelo office.
And we left the facility on that day and we were very disappointed.
Ngiyabonga.
Thank you.
We are going to the recommendations. But before we go to recommendations, I think it is important that I read what is on the National Health Act, Section 27 of the Constitution. Section 27 of the Constitution provides as follows: health care, food, water, and social security. Section 27 of the Constitution says everyone has the right to access to 1. Healthcare services, including reproductive health care, B. Sufficient food and water, and C. Social security, including, if they are unable to support themselves and their dependents, appropriate social assistance. It further goes and says the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. Let me also acknowledge the presence of Mr. Terence Magoro, the acting COO in the Provincial Department of Health and the Office of the MEC. Thank you. As we are moving to the recommendations, I'm glad that the district managers are here, as well as Mr. Makor. Kuko, this thing where you miss your appointment today, tomorrow when you go to the clinic, you are being punished. Kuti will go and stand right at the back of the queue. That is not a department or departmental standard operating procedure. Kubeko, this thing, when you move from this community to this community, kuti where you must bring a transfer letter. I am asking. Now, I am not asking as any other person. I am asking as Anele Yawa and as the General Secretary of TAC and the leader of a sector of people living with HIV. Transfer letters and making people to go at the right at the back of the queue because they have missed appointments. That must be abolished. This must be abolished. If it means that we must go to the Health Portfolio Committee in Parliament and go to all other relevant authorities to make sure that this is abolished, I am more than prepared to lead those people. But now I humbly ask that as authorities engage with facility managers, make them aware that it is not wrong for one to miss appointments. Like all of us, we normally miss appointments, be it with a doctor or with your partner for a dinner out, but there are a lot of things happening, but we do miss appointments. And when one has missed an appointment, that person must not be punished. I am a public healthcare user. I know the clinic where I go, after 1 o'clock, it's not busy in the clinic. From the morning until 1, it's busy. But after 1 to 2, it's not busy. Why don't we say at least those who have missed their appointments, instead of them waking up early, you can come to their facility anytime after 1 o'clock and collect your medication, instead of punishing people for missing appointments. And this thing of transfer letters. The reason I'm saying this is because from where I'm seated, I'm asking myself, last week we had meetings like this in KZN, Kungundlovu, Ilembe, and all of, same problems, same everything. And I'm asking myself, is there something that we are not doing right as the country? Is there something that we're not doing right as the leadership of the treatment action campaign? Because every night after these meetings, when I'm alone, I end up feel trauma and depression and anger. Because this is not what we bargained for. This is not what we voted for. This is not what made us to remove the apartheid regime for. We never removed the apartheid regime to make our people to suffer. We removed the apartheid regime in order for us to make the lives of our people better. But when I listen to these stories every night, I get angry to myself, but I cannot be angry to myself. That's why during the hard lockdown, Mr. Mogoro, here in Gauteng 2021, when people were telling us about problems they were experiencing, we took a conscious decision as TA's leaders to say, we're going to break the lockdown regulations. We're going to sleep outside the office of the premier until we are attended. Is that the language our government wants to listen to when people are having problems? Because from where I'm seated, I'm conscious of one thing. I know what needs to be done. But you know what? If I were to lead the people in breaking the law, occupying these offices until our demands are met, we will be called names. We are attention seekers. We like to disrupt. But how can you sleep peacefully when you know that a woman like that one, she was denied her right to life by an individual who does not own the health system, including the institution? We've got a serious problem, Bapat. The problem is not with the politicians. The problem is with those ones that are working inside facilities. If you were to count all these people who are here, majority of them are the ones that we are looking for in our facilities. Some have not defaulted, have made what is called silent transfer. I'm treated bad in this facility. I silently move from this facility to the other one. These are the challenges that we are facing as the public healthcare users of our country. And now we have resorted, Uguti, let's have these platforms. Because in old days, we used to picket toi, high attention seekers, that they are rude. Now we are saying, let's sit down, here is that, here are testimonies, here are the people. And we are even prepared to come in those meetings with the staff which works in a particular facility so that we can reason with them. These are our sisters and our brothers who works for the government. But we do not know what makes them to change their minds when they are on that other side of the fence. Because they are not sleeping in clinics. We stay together in the same community. But the way they treat us as third-class citizens in a country that we fought for. They treat us as third-class citizens in a country that has a constitution which protects and guarantees our rights. So it therefore means these rights only exist on paper. We want to work together with you. We want to work together with you as TAC, as Ritshidze, as PHIV sector, and as the community. Because no one wants to die. Health is a fundamental human right. And if health is a fundamental human right, that right needs to be respected by all. Both the users of the services and the providers of the services. It cannot be true that people will go to clinics sick, and when they walk out of that clinic, they are sick, traumatized, and feel that their dignity has been dragged into a mud. Something needs to be done. I'm sure this is not what majority of the nurses who are progressive and productive have signed for. That's why we are saying, let's identify the rotten potatoes and eliminate them. Because if we do not eliminate those rotten potatoes, as the community we will say, this is how the health system of our country treats us. Because why? Those in authority continues to protect the ones who are doing wrong to us. I hope that by December, maybe Paul Mashatile in Durban will tell us, or Joe Patla, they will tell us, to miss an appointment is not wrong. And you must not be punished for missing an appointment. Because if we were to take legal steps against these health facilities that are turning people away based on what is here, some of the facilities will have to pay, or those individuals have to pay for violating the rights of the users of healthcare services. To turn someone away or make them to go right at the back of the queue because they have missed an appointment, it is not a departmental standard operating procedure. It is an internal arrangement of some officials and individuals within those facilities. And we want that to be abolished. Also, this thing of transfer letters. You coming from KwaNobuhle, you got a job in Gauteng. Now you are made to go back to KwaNobuhle Tinaga to get a piece of paper. That is not fair. I am using ABSA Bank, and I can access my money at any ABSA ATM. I'm not asked a transfer letter. When I go to SARS or SASA or any other department of government, I am not asked about a transfer letter. If I were to go to Home Affairs now, they will never say to me, go to Eastern Cape. They will attend to me. But when it comes to the Department of Health, the one that is supposed to save the lives of the people, we are often told about transfer letters. Today, across the country, I am saying this must be abolished. If it is not abolished, we are going to organize and mobilize and occupy each and every government department. If it means, as the poor people, we must be arrested or we must be shot, let it be. But we will be defending our rights. We cannot tolerate this anymore. We cannot. We cannot tolerate this anymore. This must come to an end today. And if it means, it must be communicated to all political parties and tell them, in your election manifestos, you need to include this issue of transfer letters and making us to go at the back of the queue. And if you do not include it, we won't vote. We've got 8 million plus people living with HIV in this country. And if we were to stand up and tell all of them, if 1, 2, 3, 4 is not happening, don't go and vote, we will be called names. We do have power, but at times we listen and respect the political principles. But we will be patient until to a certain corner where we will not gonna take it anymore, and we will take it back to the streets. And we will break the law again until our demands are met, and all these problems are resolved. Fix our clinics, fix the attitude of the nurses, and then we will assist you in identifying people who have disengaged and bring them back to care. But what sense does it make for us to go to communities, identify people who have disengaged to care, link them back to care? When they get to care, they experience the same problem. Let's go to the community. The authorities must go to facilities to fix the problems. We will assist you in bringing back people to care. The recommendations are as follows. The Department of Health should ensure DOH staff acknowledge that it is normal to miss appointments and or have treatment interruption. People living with HIV returning to care after late or missed scheduled visit, silent transfer from another facility or treatment interruption should be welcomed. Ensure the Department of Health staff treat people in a dignified and friendly manner, and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary action where appropriate. Send communication to all sites highlighting that no person living with HIV should be sent to the back of the queue if they are late for or miss an appointment as per the national ART guidelines, where no punitive action should be taken. Ensure transfer letters are not required for ARV continuation or restart. Any reports where treatment is delayed by requirement of transfer letter should be urgently investigated and disciplinary action taken where appropriate. The Department of Health and VETS, RHI, should implement the 2023 adherence guidelines, standard operating procedures with fidelity, including ensuring every person starting antiretroviral treatment is provided with good quality fast-track initiation counseling session 1 at ART start and session 2 after 1 month on ART. Taking first viral load as early as possible to ensure providing earlier adherence intervention support and earlier access to longer treatment supply at more convenient location. Actioning an elevated viral load without delay, including funding and setting up effective abnormal result recall system and providing quality enhanced adherence counseling when appropriate. Actioning a suppressed viral load without delay, focusing on immediate assessment, offer and enrollment into repeat prescription collection strategy of choice the month after viral load is taken. All facilities implement 2023 re-engagement algorithm, including appropriately differentiating services for the returning PLHIV. Ensure the Department of Health and district support partner staff provide accurate and easily understandable information on treatment literacy and adherence, and the importance of an undetectable viral load through consultations, counseling, and outreach. Ensure that treatment literacy information is provided at health talks each day at the clinic. Ensure that the Department of Health and district support partner staff explain viral load test results to all people living with HIV properly in a timely manner. VETS RHI should ensure that district support partner staff acknowledge that it is normal to miss appointments and or have treatment interruption. People living with HIV returning to care after a late or missed scheduled visit, silent transfer from another facility, or treatment interruption should be welcomed. Ensure district support partner staff treat people in a dignified and a friendly manner and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary action where appropriate. Support with training and mentoring of the Department of Health staff at facility level on the revised 2023 re-engagement clinical and adherence guidelines standard operating procedures.
The next group of issues are those affecting key populations. Most key populations are using public health facilities to access health services, so it is important that our clinics and CHCs provide a friendly, respectful, and safe and confidential environment. Yet, despite sensitization, training, and retraining efforts, disrespect and poor treatment of key populations remain a common challenge. Ritshidze data revealed that at public health facilities, only 42% of gay, bisexual, and other men who have sex with men, 35% of people who use drugs, 64% of sex workers, and 60% of trans people reported staff are always friendly and professional. Where the attitude of clinic staff have become unbearable, some people have stopped going to the facility altogether. Clinical staff were again this year the most commonly reported as being unfriendly and unprofessional by all key population groups, followed by non-clinical staff. The majority of key populations interviewed did not feel safe or comfortable at the facility. In order for key population to access health services, and in a particular key population-specific services, spaces are needed that feel safe, comfortable, and private enough to disclose you are a member of key population group without fear of judgment, abuse, harassment, or even arrest. Disgraceful privacy violations continue to occur that destroy people's rights to privacy. 35% of gay, bisexual, and other men who have sex with men, 33% of people who use drugs, 34% of sex workers, and 45% of trans people interviewed did not think privacy is well respected at clinics in Ekurhuleni. Shockingly, many people even reported being refused access to services in the last year because of being someone who uses drugs, is a sex worker, or is a part of the LGBTQIA+ community, including 13% of gay, bisexual, and other men who have sex with men, 18% of people who use drugs, 9% of sex workers, and 10% of trans people we interviewed. This is unconstitutionally and absolutely unacceptable. Where people do continue to suffer the daily indignities of using the public health system, specific services remain unavailable. Ritshidze data reveals that very few sites provide KP-specific services, and when asked what those specific services are, it becomes clear there is little available. Key populations can't always access basic prevention tools like condoms and especially lubricants. Lubricants were only available in only 17% of sites monitored by Ritshidze. Additionally, lubricants need to be put in places that people can take them without being judged, embarrassed, or even outed as a KP. However, in some sites where they were available, lubricants were only available by reception. When we spoke to KPs themselves, 30% of gay, bisexual, and other men who have sex with men we interviewed, 38% of people who use drugs, 59% of sex workers, and 80% of trans people using public health facilities said they could access lubricant. Positively, many sites did report offering PrEP to key populations. Given that PrEP is available in 100% of sites monitored by Ritshidze in the district, this means all sites could be offering PrEP to key population, which is not true. While covering a wider and a differing set of sites, only 32% of gay, bisexual, and other men who have sex with men, 34% of people who use drugs, 31% of sex workers, and 25% of trans people interviewed reported being offered PrEP at the facility. Pointing to the reality that while PrEP is sitting in facilities, key populations are not made aware of and actually offered PrEP. The majority of people could access the contraceptives they wanted, except for trans people we interviewed. At times, KPs are refused access to contraceptives specifically because they are a member of key population group, as reported by 71% of people who use drugs and 14% of trans people we interviewed. South Africa faces a well-documented epidemic of gender-based violence, including homophobic and transphobic attacks on the LGBTQIA+ community members. Sex workers also face extreme levels of violence and forced sex at hands of clients, partners, and even police. It is critical that key population who face sexual violence feel safe enough to access the necessary services at the clinic. However, only 45% of gay, bisexual, and other men who have sex with men, 54% of sex workers, and 56% of trans people taught staff were well trained to care for those who experience violence. Harm reduction services remain out of reach to people who use drugs. Only 4% of people had been given information about where to get new needles. Only 12% of people had been given information on where to get methadone, and only 11% were able to access drug-dependent support. Gender-affirming services are critical, yet only 33% of trans people say facility staff are always respectful of their gender or of their gender identity. 38% said that healthcare providers use their wrong names, and 63% said they use their wrong pronouns. 61% of trans people we spoke to wanted to access to hormone therapy at public health facilities, and many clinics were unable to even provide information to trans people about where to find them. Now we move to recorded stories. Thank you.
Shooting edit, yabo. Just mama apply the rehab, yabo. Shooting clinic being a medical. Obvious, I'm expecting with bang buzing to phone and I'm going to impede into Nama security or no no can about boozes of Funa no abuse with can duck Funua. Then to but he scheduled 6 but I made above the back need and she was sitting car methadone as a rehab sister.
We now move to community members that have joined us in person.
Sanbon ngathanda ukuthi ngibe anonymous. Istory sami ukuthi mina bengibhema vele ngumuntu obhema ama drugs ngiqhamuka eDavidson.
I am from Davidson and I'm a person using drugs.
Ngadibana ne challenge ukuthi ngathi mangizijova esandleni umjovo like injection yakhona yaphukela phakathi like mangiya ekliniki ngifika like ngithola unesi naye mangithi ngikhuluma naye ukhuluma kwakhe ukuthi why wena bo wenza kanje na istory like iziba yiningi ugcine ngagcina sengigive up vele nendaba zekliniki sengihamba ngiye emakhaya eKZN ngayohlala khona lapho khani ngathola khona usizo ke ngoba sengiright nje manje ikliniki bengasayingini nokuyingena vele kumanje angiyivela nginindaba nokuba nindaba.
So as a person that I was using drugs, I once injected myself incorrectly and the needle broke in my hand. I then rushed to the clinic, but the nurses in the clinic, instead of assisting me, they were judging me and they were telling me why I was taking drugs, and they said a lot of things to me. I ended up relocating back home to KZN, where I got assistant of rehabilitation, as I have now stopped taking drugs. Then I got back to Joburg, now that I'm residing here in Joburg, but I have no energy whatsoever to go back to the clinic. I'm not using any facility, healthcare facility for my health. Thank you.
Sanibonani.
Greetings.
Ngihamba eclinic yase Davidson Clinic.
I use Davidson Clinic in Davidson.
Story sami it happened ukuthi I went to the clinic and what happened? Oh, I went to the clinic and I think being a drop.
So I went to the facility when I thought I had an STI.
So a clinic back was okay. You said you have a drop. What happened?
So at the clinic, they asked me many questions and they asked me what really happened. How did I get the infection?
So mangba explainela ended up ukuthi mele ngiexplain ukuthi I'm a XW.
So I had to explain myself further and further to a point whereby I had to explain that I'm actually a sex worker.
So mangiqale ngiba explainela ukuthi I'm a sex worker, that's where they start uba surprised because I remember unesi uyele wakhulula nama specs. Waba like eh?
So when I then told the nurse that I'm a sex worker, the nurse was very shocked. I remember that day she even had to take off her glasses.
So makhulula ama specs ka so what's umncane ka so beka umuhle kanjani mara wenza amanyala so.
And then she further reiterated that I am handsome and I am young and I am doing, yeah.
So makasho kanjalo ay nami ngavele ngabaseleka. Ngambuza mina ukuthi kanti nesi uzongisiza or wena uzozenza ngcono ngami la.
So as the nurse was speaking to me saying those things, I got angry myself and I started asking if she was gonna help me or she was gonna make herself better than me.
What's awunawo namahloni uyadelela nokudelela uyaphendula.
And then she told me that I am not ashamed, I'm even disrespectful, I'm even answering to her.
So I end up ngaxolisa ngathi uzongisiza na.
Then I ended up apologizing and asked again if she was gonna help me.
Wathi awungiyeke mfana wami mina ngisaye lunchini ithi ngizokubizela umuntu ozokusiza. So the other nurse came okumele angisize. So bekumele ngiexplain again futhi.
And then she told me then she was not gonna help me as she was going for lunch, but she was gonna call somebody to come and assist me. And when the next nurse came, I had to start afresh to explain myself.
So from there I vele nami bese ngizikwatele plus vele mina ngine pride ngavele ngangala ngathi ayinesi ngiyabonga ngizobona ngenza kanjani. So I ended up vele ngasangizizwa ngeclinic. From there vele mina neclinic ahlangana.
So because of, I also have my own pride, I couldn't re-explain myself to the next nurse. Then I just got angry and said, you know what, it's fine. From that day, I no longer go into the clinic.
Ngiyabonga.
Thank you.
Sanibonani.
Greetings.
Alokhulumaya uKhanyo kaNkabinde. I-challenge engadibana nayo eclinic ukuthi ngaye eclinic ngivele irush ebusweni. So ngathi ngifika vele eclinic ngacela uncedo ngoba zange bangincede way banceda abantu ngakhona because of I'm a transgender woman. Zange bangiphathe kahle.
So I went to the clinic when I was not feeling well. I had rash in my face particularly. But the treatment that I got in the clinic was unfair to me as a trans woman.
Into vele yaba worse kakhulu ukuthi ngila ngacela ukuthi banginikeze nama lubricant bangitshela ukuthi wayengayozithengela ama lubricant necalamine ngoba azikho izinto zamahala kumele ngisithengele ngemali yami.
And what made worse for me in the facility, I then asked to be given lubricant. And they told me that I must go and buy myself lubricant and I must also buy myself calamine because there is nothing for free in life.
So ngila ngachinja iclinic ngaya Davidton East Clinic. So njengoba ngishintshe iclinic yonke into bengifuna nanoma ngigula bayanginceda eclinic bangitreata njenga wonke umuntu abangitreat kabi because of I'm a transgender woman. Thank you ngiyabonga.
So from there, I self-transferred myself from this particular clinic that I was using to Davidton East Clinic. The treatment that I'm receiving in Davidton East Clinic is better. They treat me equally with other people. They're not discriminating me because I'm a trans woman. Thank you.
Sanibonani.
Greetings.
Ngicela ukuba anonymous.
Yes.
Mina I'm a sex worker. Then it happened ngelinye ilanga like mina isport engisebenzisayo sise Greenfield. So normally like anginayo indawo straight. sometimes ngizothatha umuntu ngihambe naye or whatever. Then the other day it happened, then ngihlangane nabanye abobhuti abayi-2, they offered ukuthi bahambe nami ngiye la, bafuna ngiye nabo. Then saya, masifika, azange bangiphathe kahle, bangirape, bangishaya. Then I had to ukuthi ngihambe ngiye clinic. Then mangiye clinic ePhamrichi, treatment yakhona bengekho right. Amanesi angitshela ukuthi ngoba ngumakhoshe, whatever yenzeke kimi bengideserve. So like ngazibuza ama question ukuthi kanjani, I mean like nginama reason wami ukuthi wayenza lento engiyenza and akusi concern yabo wabo umsebenzi ukuthi if mangabe ngiza ngigula or kwenzakalani kumele bang assist hayi ukuthi bangibuza ama question amaningi. So bengathanda nje ukuthi
Okay, so I'm a sex worker residing in some area. I do not have a specific spot where I am working. I work in different areas. So it happens this day that 2 guys came and they took me in the car and I went to their place. And when we arrived there, they then did not treat me well. They ended up raping me, and then I went to the clinic. At the clinic, I met nurses. It's Palm Ridge Clinic. I met nurses who told me that I deserve whatever that has happened to me because I am a sex worker. I did not understand what gave them the right to judge me because my understanding was that when I come to the clinic, for them was them to give me health care.
so bengathanda nje ukuthi ugovernment nathi singabantu ayenze nje ukuthi kube legal yabo sizokhona ukuthi sibe safe.
Okay, my other plea is that we as sex workers are also human beings, and my plea is that the government must legalize sex work so that would contribute to our work being safe. Thank you.
Thank you. Thank you. You know, as I'm listening here, we're going to recommendations and we're going to be fast. As I'm listening here, say, Mr. Makor, I am asking myself, there is a war between, in fact, the Palestinian people are colonized and are oppressed in their own land. And every day we hear the gross violation of human rights in Palestine. And we as political activists, we are clear, we are in solidarity with people of Palestine who are saying from the river to the sea, Palestine will be free. And I'm asking myself, how does it happen that we go to Palestine, yet we've got our own Palestine in South Africa, which is our clinics? The indignity, the gross violation of human rights people of Palestine are experiencing against the people of Israel is what majority of us are experiencing from some of our nurses in our clinics. And I'm asking myself, what sense does it make for me to support Palestine, yet the people of my own country are dying in the hands of the people that we have hired as the state? But also, it's like some of these people who are hired by the government, by our government, are coming from another planet where they do not understand the living conditions of our people in our country. Where it seems as if they do not understand that we've got the high unemployment rate, which leads to some decide to do sex work as part of work, as means to make money. Where in the country we've got a Bill of Rights which talks about freedom of association and freedom of choice. Because we normally see young people when go to clinics for a termination of pregnancy, or the gays, lesbians, when they go to our clinics for services, instead of them being given services, they are being ridiculed. They are being made to feel that they do not exist. And that's not what our constitution gives us a guarantee about. And you begin to ask yourself whether these nurses or some of these nurses in our clinics and other people who are working there, whether they have been given a mandate by the department to do this. And if they are not given a mandate by the department to do all these gross violation of human rights, what is the department doing about that? If me, as an employee of the government and of the department, I make James to disengage from care, it therefore means I have violated the rights of James. And my employer must do something about that. Don't ask me, Uguti, there are complaint boxes and suggestion boxes. Those things are just like ornaments. They do not work for the people. People keep on putting complaints there, but they don't get a feedback. Instead of them getting a feedback, they are being identified and eliminated by some of the nurses. Kuthiwe yambona lo unamadevu mfutshane, ngulo wala complain. Ngulo be complaining ngawe sisibani. Usister Bani and other colleagues will adopt the attitude against Luana who laid a complaint, and as the result, the community decide not to lay complaints. When you speak out, you will be identified and eliminated and not be given proper services. So our community decides to keep quiet because they do not want to be harassed. This is a sad story, and we need to work together. This time around, we cannot blame the politicians. I think the officials and us, we need to work together. If it means we must convene meetings together with your department and healthcare workers trade union on how Denosa and all what have you, sit around the table and say, Tina, we are the users of healthcare services. Your members are the providers. This is what we go through, some of your members. We need to get a political commitment from the unions that represent some of these healthcare workers so that we know, Ukuti, by means of trying to fix the problem, we reach out to everyone, because when one nurse, something happens to him or her, unions are the first ones to stand up and speak out. But this must be a two-way road. Even us as communities, whenever we do something, it is good that we are held accountable, but also nurses must be held accountable, one, in their capacity as professionals, as well as in their capacity as individuals. So the recommendations are as follows. Ensure that all clinical and non-clinical staff, including security guards and cleaners across public health facilities, are sensitized on provision of key population-friendly services to ensure a welcoming and safe environment for all key populations at all times. Key populations must be involved in the implementation of these training modules. Any reports of poor staff attitudes, privacy violation, verbal or physical abuse or harassment and or of services being restricted or refused should be urgently investigated. The Department of Health and PEPFAR should expand the Centers of Excellence model to ensure that at least 2 public health facilities per population in Ekurhuleni serve as key population designated service delivery centers. A minimum package of service should be made available at these facilities as outlined in the State of Health report. Easy referral and adequate resources, including transport or money for transport, must be provided for people to take up these services. PEPFAR must support these facilities with additional key population-friendly staff and resources to provide comprehensive health services to the specific key population being served. Ensure that HIV prevention tools, including lubricants, external and internal condoms, PrEP and PEP, are made easily available at all public health facilities. Make available external and internal condoms as well as lubricants in a range of spaces across the facility. For an example, waiting areas, toilets, gate, pharmacy, consultation room, quiet areas out of sight, so people can freely and easily collect them. Ensure that PrEP is offered to everyone, including key population who are not living with HIV or test negative for HIV with information shared on its benefits. Ensure that all facilities provide gender-affirming services, including using trans people's correct name and pronouns, providing a gender-neutral toilet for trans people, respectfully asking trans people which color folder they are more comfortable using, pink, blue, or yellow. Ensure that trans women are not made to use men's corners. Maintaining privacy and confidentiality. Additional healthcare workers and clinic staff should not be called into consultation rooms under the guise of helping, when often this is to mock and judge trans people.
The next group of issues are on index testing. 100% of facilities monitored by Ritshidze engage in index testing. And of the 1,024 people living with HIV interviewed, 58% said a healthcare worker had asked them for the names and contact information of their partners to test them for HIV. In terms of consent, 92% reported that they were allowed to refuse to give the names of their partners. While index testing has the ability to help identify individuals who may have been exposed to HIV earlier, it must be implemented in ways that do not cause harm to individuals or undermine their rights to consent, privacy, safety, and confidentiality. 18 sites had perfect scores, with 100% of people reporting that the staff told them they could refuse. However, at some very few people knew that they could refuse, as shown in the table. Index testing must always be completely voluntary. 93% of facilities say they screen for intimate partner violence as part of their index testing protocol. Of 593 people living with HIV, 87% reported that they were asked about the risk of violence from their partners. All facilities must screen for intimate partner violence in order to avoid violating people's safety. Of those who screen, 29% still contact all partners regardless. There is no point screening for intimate partner violence screen if contacts are just notified of their exposure anyway. 10 facilities had 80% or less people reporting being screened of intimate partner violence. There must always be an intimate partner violence screen to protect people's safety who undergo index testing. Most sites said if people living with HIV screen positive for intimate partner violence, they offer them services either on site at 67% of sites and or by referral at 46% of sites. All facilities should be able to provide on-site or referred services for intimate partner violence. Screening for IPV without adequate services to respond to an individual's positive screen is dangerous and unethical. Referrals must be actively tracked to ensure individuals access them, and referral sites have adequate capacity to provide services to individuals. We now move to recorded stories.
Mina ngihlala eWardville, ngithatha i-treatment yami eLithabong. Ngithatha i-treatment ye-HIV. But ngengathi bengifika eLithabong ngahlangana ne-problem yokuthi bafuna ukungithatha i-test le yasemunweni. But manje bafuna ngize ne-partner yami. And ngabatshela ukuthi angisazi i-status se-partner yami and ngiyayisaba isikhathini esiningi. Azange bafuna ukunginceda. And next time bengibuyela azange bafuna ukunginceda because angizanga ne-partner. So nga-end up angatholanga usizo until now. Okay, so lesikhathi bangithatha le test yasemunweni since ngikuma-ARVs from March until manje. Ngaphambi kokuthi bengidefaultile angakaphuza treatment namanje. Ngizizwa ngingaphathekanga kahle.
We have one community story in the house. Oh, okay. All right. So we'll move straight to recommendations.
Thank you, James. The Department of Health and VETS RHI should follow up protocols outlined in the National Department of Health guidelines on index testing, including that index testing is always voluntary. All healthcare providers ask if the individual's partner have ever been violent and record the answer to this question before contacting the sexual partners. No contacts who have ever been violent or are at risk of being violent are ever being contacted. Adequate in IPV services available at the facility or by referral. Referrals are actively tracked to ensure individuals access them, and referral sites have adequate capacity to provide services to the individual. All adverse events are monitored through a proactive adverse event monitoring system capable of identifying and providing services to individuals harmed by index testing. Comment boxes and other passive systems are necessary but inadequate. After conducting the conduct, healthcare providers must follow up with the individuals after a reasonable period of 1 to 2 months to assess whether there were any adverse events, including but not limited to violence, disclosure of HIV status, dissolution of the relationship, loss of housing or loss of financial support, and refer them to the IPV centers or other support services if the answer is yes. Data on such occurrences must be shared. Carry out an investigation into all Department of Health and district support partner staff carrying out index testing to assess the implementation of index testing. The findings of this investigation should be shared transparently. Suspend index testing in poorly performing sites until it can be carried out safely and with consent.
The next set of issues are on infrastructure and clinic conditions. The country's load shedding crisis negatively impacts the provision of healthcare in our clinics and can often lead to people waiting much longer to collect medicine or consult with a clinician. In Ekurhuleni, the most common challenge including data captures, not being able to capture information, creating a backlog and impacting follow-up with people who have missed appointment and other recall system. The delays in finding files when filing rooms are in darkness. Generators at each facility could resolve these challenges, yet only 51% of facilities reported having a generator that is working and has fuel. Positively, 98% of facilities monitored in Ekurhuleni were observed to be in a good condition. The only sites reported as in bad condition was due to the building being old and in need of renovation. 54% of facilities reported needing more space, with waiting space, filing space, room for medical care, and private HIV testing and counseling. Given as the most common things facilities needed extra space for, impacting negatively on congestion, TB infection control, waiting time, and privacy. On overall cleanliness, 76% of public healthcare users reported that the facilities were very clean, while 6% reported that facilities were very dirty. The cleanest sites are outlined in the table shown, and the worst performing sites are outlined in the table shown. 43% of Ritshidze observation found that toilets were in bad condition, with toilet being out of order, no soap and no toilet paper given as the most common reason. Now we move to the recorded stories.
Erin Clinic. Singing more than 5 years in his clinic. Umpumedlini was 7 o'clock. Ngizofika la 7:30. Ufika la 8 o'clock exactly umsebenzi awuqala. Sometimes besibeqala ngabo 10. sihleli ngaphandle la kuyabanda sibulawa ngamakhaza imvula iyanetha sinethwa imvula. As you guys can see, there is no shelter. And how many people are there? Less than 50, but it will take for the whole day to service all those people. People are fainting, especially like elderly people sitting on the sun. I will be happy if they can make a shelter here so that we can be under the shade. They are always complaining also about the shortages of nurses. We don't understand why in South Africa we've got the shortages of nurses. And some people are sitting at home with qualifications. We just need better service. Better service. That's the only thing I can say, a better service. And it should be quicker.
I'm a patient here at Erin Clinic. I'm taking my medication for chronic, and then I stay here in Tlamatlama. The challenge that renal in our clinic, the spacing. The clinic is too small to accommodate the community here. If they can extend it so that we can all fit in that clinic, because we have to wait outside, because they can't put everybody at the same time in the clinic. And then for us to be queuing outside, it's because there's not enough space inside the clinic. Yeah, maybe if they can maybe put a shelter, like when it's raining, it's difficult.
Ngamisa khona la ekliniki nini lo shading yacima igesi sebacosha abantu bacosha ama patient yebo bathi safety yabo ngaze ngababuza ngathi impilo yomntwana shuthi ayibalekanga ukudlula isafety ababizi ambulance sister generator isebenzi.
Or we're going to recommendations. The Department of Health should ensure that all public health.
Hi, how are you?
Department of Health should ensure that all public health facilities have a functional generator with sufficient fuel and rechargeable bulbs so that health services and administrative work can continue during load shedding. Ensure that all public health care users are consulted, tested, and or counseled in private rooms. Carry out an audit of all facilities to assess infrastructural challenges, after which the department should develop a plan in order to renovate buildings and ensure adequate space to provide efficient, private, and safe healthcare services. The department must publish the audit results. In the interim, provide temporary structures and ensure that more people living with HIV are being decanted out of the facility and receiving longer ART refills to reduce the burden on overcrowded clinics. Ensure that all facilities are maintained to the highest standards of cleanliness, including through implementing regular cleaning rotas. Ensure clinics have resources to provide soap and toilet paper in all toilets.
The next group of issues are on TB infection control. In South Africa, around 300,000 people develop tuberculosis every year, and about 56,000 people die. Yet, TB infection control in our public health facilities remain inadequate. By following a simple checklist of good practice, including key measures that were implemented during COVID-19, facilities can be safer for public healthcare users and staff. With the checklist in mind, Ritshidze has developed a scorecard and a traffic light system to rate clinics on how good their TB infection control is. Clinics that adhere to all measures are given a green light. Those that are on the right track but still off target get a yellow light, and a red light is given to clinics that are way off mark on ticking the checklist of the 6 measures. In July and August 2023, no facilities were awarded a green light for checking all 6 measures on the scorecard. 12 facilities were awarded yellow status for following about half of the best practice measures for infection control. This leaves 28 facilities surveyed that failed altogether at meeting these 6 best practice practices to stop the spread of TB?
Yes, we're going to recommendations. But as we are going to recommendations, I think on our side as Ritshidze, also we've got a responsibility to make sure that, I do not know how, but we need to reward health facilities that are doing well in certain areas so that it can be noted, Uguti, we are not only looking for faults or mistakes. Where good work is being done, it also gets rewarded. We're talking about TB. According to the World Health Organization, in South Africa, we've got about 56,000 TB deaths a year. And out of that 56,000, about 33,000 of those people who are dying of TB annually are people living with HIV. TB remains one of the killer diseases in our country, and TB is curable. But the problem that we have, the effective TB drugs that are available are still expensive for all of us to access them. TB continues to kill more people than COVID-19. A day, 150 people are dying of TB a day in South Africa. And we do not see TB the same way we look at COVID. That's why, as TAC and other progressive forces, 2021 we marched to the Deputy President, Didi Mabuza, and Minister of Health, Dr. Zweli Mkhize, in Mbombela, calling upon our government to declare tuberculosis a national health emergency. We were calling upon our government to do to TB what our government has been doing to COVID, including political will, political commitment, as well as injecting more resources. During lockdown, you knew when you go to the bank, you will be screened. But when we go to our clinics, we are not screened for TB. Even when you are coughing, you are not treated with emergency, being given a mask and all those things. So we need to treat TB the same way we treated COVID-19 and HIV. Our recommendations are as follows. The Department of Health should issue communication to all facilities stating that all windows must be kept open. If we can tell these comrades next door, they are disturbing us with that noise. Issue communication to all facilities stating that all windows must be kept open. TB infection control posters must be displayed in visible places in the waiting area. Public healthcare users must be screened for TB symptoms upon arrival. People coughing or with TB symptoms must be seen first to reduce risk of transmission. People coughing or with TB symptoms must be provided with masks. People who are coughing must be separated from those who are not coughing while waiting. Carry out a full audit of all public health facilities in the province to assess TB infection control based upon World Health Organization guidelines, after which the department should develop a plan based upon the infrastructural, human resource, or behavioral challenges found in order to improve TB infection control. The department must publish the audit results. So that brings us to the end of our report. Now, I've got 10 minutes for leaders of the PHIV sector. All of them will see how do they use that 10 minutes. And then after that, we will give to VEDS RHI and we will give to department. I do not know whether the MEC is still online. And then if the MEC is still online, as the protocol dictates, the MEC will be the last person to speak. So now, I've got 2 minutes for each of you, Gemakaban. I'm going to call Comrade Phumzile Mbambo. You've got 2 minutes, Comrade Phumzile Mbambo from Napwa. Going once, going twice. Okay, thank you. We're going to call Comrade. No. I'm using a wrong one. Sorry, comrades, sorry. I'm using yes a KZN. I'm gonna call comrade George Ngos. George Ngos. George Ngos. Going once? Oh, kuthiwa ucomrade George Ngosi akekho. Sino comrade uSimangele Mkhulisi from Positive Women's Network. I'm not gonna sit down, comrade Simangele. Kwenzele, if you exceed 2 minutes out, the floor is yours.
Sanibonani, igama lami nguSimangele wakamkhulisi, ngibuya eWhiteville, ngiyi-PWN member, also nguku-district leader. So nami ngulo party yabantu abahambayo bayo monitora kuma-clinics. So sinokuba nawo ama-challenges, at the same time kukhona amanye ama-facilities lawa aya-improve. Eyokucala njenge-Bosberg North, i-building yakhona iyakudala and incane and inama-patients amaningi aza lapha ku-facility. Nakhona nje ukuthi staff asikho enough. Bese kube khona iLithabong. iLithabong akusi ikliniki eyakudala, but incane nayo inase ispace mara asinama rooms are enough to meet ama patients. Uthole ukuthi sometimes kunabantwana besikolo baza laphana bazofuna like mhlambe like ama-injections or abomama abantu besifazana abazoza for i-pap smear, batholakala ukuthi ama-equipment for i-pap smear abanawo. Abantwana besikolo bazofuna ama-condom, thothi ama-condom awatholakali kuma-facilities. Ngiyabonga.
Thank you, comrade Simangele. Ungabi sayihambisa imic, sonikeza uBishop Sibeko apha next to you. Over to you, Mfundisi.
Umfundisi ke lo. Sanibonani nonke. Niyaphila. Siyabonga. Thina njengesanarela besingathanda ukubona ukuthi njalo nasihlezi nama hierarchies we Department of Health. Lezi zinto esikhuluma nazo nabo ngazo bazi attenda. Ziningi izinto ezirong ezisavela namhlanje. Ever since saqala ukukhuluma nabo ziyamentionwa lezi zinto. But there is no changes. Subona nje umehluko. Like ama files asalahleka namhlanje. Ma toilets asafile namhlanje. Bantu basahlala emakliniki kushawa 4. Umuntu ufike ngo5 ekseni uzama ukuthi asheshe aqede abuyele emsebenzini. Nakafika esibhedlela abodokotela bekho bayashota, staff siyashota. Now ukhuluma ne-facility manager nakutshela kudala nami ngicomplaina ngalezi zinto azilungi. Asisazi thina manje kanti ukuthi kumele sikhulume kanjani nabaphathi be-Department of Health. Recently besihlezi nabo eJimmiston bekhona bonke balama department lawo kumele asebenze ibhedlela. We hope ukuthi njengoba sikhuluma nabo things will change. After 2 weeks sibuyele ema-clinic siyo check sithola ukuthi instead kube right kuba worse. So asazi manje ukuthi kumele sikhulume kanjani. Siyacela asilwi nani, sisebenzisana nani. So siyacela kakhulu uma ngabe kukhona iproblem saziseni phela, thumelani report. District siyahluleka or Ritshidze siyahluleka ukuyilungisa lento ngeproblem so. Sihlale sazi nathi singabuyi sizocomplaina ngaleyo nto. Let's complain ngayo futhi na next month is complaina ngayo. Thank you.
Sabonga Mfundisi. Ngoku sizawubiza ucomrade uJake Hlasana. Ophuseletho nango apha ecam kwakho ke. Sikunika 2 minutes ke Phuseletho.
Okay. Dumelang. Le kae? Lebitso la ka ke Phuseletso wa Hatsotetsi. Ke tswa from Tsakane branch. I represent Treatment Action Campaign. I'm also a leader, yeah, the district team. Rona as really TAC, we support the Ritshidze data and report, and we applaud the good work. Who the challenges that we facing when we do our patient surveys? That's one pele, the long waiting times, the issue ya infrastructure. O thola gore motho la ha tlile tleliniking ba mo khutlisetsa morao because of asna transfer letter or ID. And as Treatment Action Campaign, we stand firm and strong ka taba ya advocacy. So whenever una le mathata ha o ya tleliniking, call us and we will be there for you. And then I'm gonna touch base on taba ya key populations. Most of the key populations, they face the name calling, ya verbal abuse. Othola hore a patient ile tleliniking and then ulo batla di loop ba re ya fana mos ina ba qeta ma loops. So motho a khutlele morao wa sena tsona ntho tseo, and yena motho ha wa tshwanela ga di reke di mahala. So please, thank you, sir.
Thank you very much. So without wasting time, we're gonna go to VETS, RHI. I do not know the protocol as a VETS with Yamanjan, but there is a mic there, Ngokel, behind you. Moya wami angiqala bazokuba you are going to respond.
Thank you, Program Director. Maybe my name is James Kabelo Letswalo. I'm working for VETS RHI as the technical lead for care and treatment. I'm basically responsible for the teams on the ground in the supported facilities within Ekurhuleni here. Maybe just to take an opportunity to thank the MEC and the office, because coming here, the MEC was just giving us a welcoming speech. The provincial managers that are here, those that I know and those that I don't know, the Office of the Chief Director, I'm aware it's represented here, Chief Director Ekurhuleni, and the managers for both DOH and COE that are here from Ekurhuleni. And just to indicate that all protocol observed. Yes, it's a bit tough for us. Remember, we are the DSP, the District Support Partner, and we have to speak. We cannot in any way represent the department or speak on behalf of the department, but we'll have to speak to maybe first in terms of the reports that has been highlighted here and the role that we must play as a DSP, acknowledge and thank Ritshidze and other partners that are supporting them in terms of this good work that we have seen. So I must say right at the beginning that as a DSP, the District Support Partner for Ekurhuleni, we will definitely support the areas that are highlighted as a DSP. But maybe in just a short period of time, let me speak to some of the areas that we are really doing on the ground so that everybody can be aware as to what is that we are doing. Of course, one of our mandates is to augment the department in terms of the human resource. When we include managers, we have plus minus just over 870 personnel that is supporting the district here in various capacities. But very critical will be our nurses, just plus minus 50 of the nurses that are supporting critical facilities, and the category or patient navigators that are actually assisting and supporting the patient in terms of taking the treatment, including your telephonic and physical tracing activities, just over 114 there. And of course, what is critical in the health space, the issue of data management is very, very critical. We do have some data capturers. Actually, we do have data capturers in all the facilities. I was just picking the most important cadres. We've got many that I can speak to. Then, of course, our role as a DSP is to support the 95 strategy, right from HIV testing, which include this topic that was very important, the last topic on index testing. Very, very important input that was highlighted here. So we are supporting that area. We have also noted the issues that were raised around index testing, and we will then go on the ground and ensure that everything is done by the book there. We also supported the second 95 in terms of initiating patients on treatment, which is a major one, and we, through these nurses that I've just spoken to, we really support our patients by ensuring that they are initiated on treatment. And the last one is making sure that they remain on treatment. We do a lot of work in terms of telephonic tracing of the patients and physical tracing. We go to their homes. We are on the ground every day tracing these patients to bring them back into care. While there, I must say, Mr. Yawa, the issues that you have indicated, reasons, some of the reasons that really chasing patients away from facilities, we embrace them as a DSP, and we promise to do our best in terms of making sure that we retain, we bring back as many of these patients into care. Of course, while it's going to be also important for both us as a DSP and DOH to ensure that the Welcome Back campaign that we emphasize is implemented religiously and with fidelity, if I have to put it that way. The issue of records management is very, very critical. We do have a records management team that is stationed in the facilities. I can tell you that we have appointed just over 40 of the clerks to support this activity. The Office of the Chief Director can also confirm the facilities that we also supported in terms of records management project to ensure that some of the issues that were highlighted here are addressed. Of course, it's a work in progress. We are not yet there, but really we're trying our best to ensure that we support that area. The issue of patient literacy, it's the in thing. We cannot afford not to ensure that our patients are capacitated in everything. What I'm picking here is we've got a huge gap in terms of capacitating our patient around viral load management, and that's what area that I've picked. And through our patient literacy team, it's an area that we'll definitely go into. The psychosocial part, very, very important, and this includes the IPV and GBV. These two areas were also highlighted. We do support this area through our psychosocial team, and hence adherence counseling sessions that are offered to clients. You can name them. So we'll also ensure that we intensify in this area. And in terms of the key populations, we are funded differently as DSPs. We work very closely with other funded DSP in terms of ensuring that implementation of our key population strategy on the ground is done. As it is now, we are working with NACOSA to render the sensitization training among the key stakeholders. It's a project that is going on. I know for sure through Oram Key Pops, the two facilities that are supposed to be your model of success, they are also in place, and we work with them on a day-to-day basis. We, as a DSP, our role is to ensure that on a quarterly basis, we have these meetings, physical meetings, and we direct activities that must happen, and we identify the gaps, whether it's linkage to care gaps or any other gaps that are there. We really support in that area. But then we call each DSP or support partner to our office, and we engage directly. That is, the meeting is quarterly, but in between, we do have these sessions or those meetings with individual DSPs. There's an issue, in closing, there's an issue with load shedding. We've tried to support this area in terms of uninterrupted power supply. We bought some of these to support specific clinics, but you would agree with me, the extent of this challenge it's huge. But really, these are some of the areas that we are really supporting. In closing, I just want to indicate that we'll continue to support the Ekurhuleni Health District in terms of the interventions. We do have a standing SLA with them, and therefore we are mandated to ensure that the activities that are outlined within that SLA, they are implemented. So our commitment in that regard cannot be doubted. Thank you very much, Chairperson. Over to you.
Sabonga, Vets RHI. Unfortunately, the MEC was waiting, but now she had to go back to the legislature. But we're gonna give to the district, and after the district, we're gonna give to the acting HOD, who is gonna join online. And the Hazgi protocol district is and funguti rai, umama kanyu tata. But each district will decide. Over to you, district. We can give the mic. Oh, Dad.
Okay, thank you so much. Thank you, Program Director. Okay, thank you, Program Director. Thank you to the Ritshidze project. It was a well-documented research, and I'm really very happy to see it. And then thank you to the MEC, and thank you to Mr. Makoro. He's at home. He's really at home. He's the Chief Director for Ekurhuleni District. Thank you to the vet. We are always working together with the vet. And all the bullets were sent to us, the district. And what I would like to say, just to apologize, especially to the mom who lost the child. Just with the security, it's very painful. Would like to apologize, sorry. And for everything you've said, you just send the bullet to us. We'd like to apologize. But Anele has been sending the bullet to us and also defending us. I was really very happy when he said, you need to fight for the budget cut. Please, you must go for it. If the budget is cut, you know the impact. We'll try to sort our problem. We have listened to it. Last week, the department have launched the I Serve with a Smile. With that I Serve with a Smile that was launched, if it's implemented fully, I think all the attitudes will go away. Please, we just pray for this launch to be fully. And I agree with everything, but with the referral, I did not fully agree with you as a medical doctor. Why? If you refer a patient, even to Calafon or Charlotte Makeke, wherever, you need to write the referral. But maybe what we need to do is a patient without a referral need to be seen. We can't say you don't have a referral, we are not going to see you. The reason is, in the referral, they'll tell you, they need to write the baseline, the viral load, and so on. If you don't have the referral or the treatment that the patient is taking, if they don't have it, it will be very difficult there to start afresh. Maybe this is a discussion, we're not going to take it here. Maybe we can just ask the vet to come with another strategy. If the patient do not have a referral, what can we do? Just to get those information is very critical, the patient laboratory results. It's very important. Maybe to say we need to phone or whatever. Please, we need to be very careful about this referral. It's the only thing that I need to argue with Anele. But let us ask vets if they can come with a strategy. If a patient do not have a referral, what to do. Then we'll take it from there. Thank you so much.
Siyabonga. we are moving towards the end. Anzo respond at that. But someday I am going to respond to say, if I do not have a referral, what do we do? The same thing that we are doing when my file is missing as a patient is the same thing that happens when I do not have a referral. So if I am able, or the facility is able to lose my file and my medical record is missing, what is the difference on the other hand when I do not have a referral? Because it's the same thing. But yeah, we will engage. Let me not make this a political discussion. But again, like Lango Makarengo, Lango Makarengo, it masibambane ngezandla. That's what we want as all of us here as public health users with the department. Sibambane ngezandla, sisebenzisaneni to improve the quality of services on the ground. Because at the end, we are not the enemies. We are going to call upon the acting HOD, if Segakona online, to comment and make some closing remarks so that we can close. Yeah. Ukonu acting HOD on the line. Akomdu.
The corner chair.
I'm here, Chair. Benza reporter MEC. Over to you, acting HOD. The floor is yours.
Now, you just finished a very nice song. I thought we'll continue on the theme. Or Wambisana. Maybe let me take the opportunity to thank the colleagues. And at the outset, and I really have two things to say. One is we, at a principal level, we accept the data and the information provided in this meeting. It's insightful, it teaches us, there's a lot of lessons learned. Having been part of these sessions in the past 2 years, I think we are getting somewhere. There are improvements in some areas. There are areas that we are still struggling. Improvements in terms of waiting times, struggling in terms of the issues of the referral, health promotion, and other related issues. I think using this data to make informed management decisions going forward is going to be very helpful. And we thank yourself for doing the work under the difficult conditions. Also, maybe take the opportunity also to apologize to that. Into those, the way nomenclature you use for the recorded stories of the users and how they've experienced positive and negative experiences of our facility. I think where we at, because of the volume, the size, the complexity of the public health system we are running, we'll probably apologize and we'll use some of those lessons learned. And as the doctor just said from Ekurhuleni, using campaigns like Accept with a Smile and others should help us improving the quality and the service that we provide to yourselves and the public. So with that, and of course the partners that make this possible, and I will not necessarily list them in no particular order, but all partners that enable this work, support the department, and are funding us and in the shortages in areas where we are short and augmenting the services that we provide. We continue to really indebted to yourselves, and we hope those that fund yourselves to assist us find it within their hearts to continue to avail those resources that assist the citizens of this country. We meet and we find each other in this work that we are doing. With that, and without being long, let me thank everyone for the participation. We'll endeavor to join you for the rest of the week where, as you are doing this in other areas of the province. Thank you so much, Kelema.
Siyabonga acting HOD. Sibonge ku acting COO, sibonge ku MEC officials and umphakathi. But acting HOD and COO, I humbly request, including you, Comrade Monwabisi, that we convene an urgent meeting with the MEC of Health. Make sure that we invite all district directors so that we can be able to present these reports and not talk about what is on the reports and talk about a turnaround strategy. I think district directors also need to convene meetings with facility managers. Sibone ukuthi senza njani together with facility managers to convene community meetings where a facility manager will go to the community, listen to the community, and be able to share with the community ukuthi what services are available with facility, what changes, because some of these changes, they just happen over a night without the community being informed. But in the main, it will be good if we can convene that meeting with the MEC. I will be glad, if possible, we can have that meeting before the 1st of January. If it means I must not go home, I am more than prepared in order for us to have this meeting. But kukusisi lawyer, now we need to assist to sis and any other community member here who was unable to get a treatment. We wish to work with you on that. But also, as we are closing, it is important, Zingokeli, Uguti, we look at this from this angle. Uguti, if all these cases, we were to go to Goma Human Rights Commission, Office of Health Ombudsman, and other law firms, many people from the department were going to be sued. And one way or another, each department was going to incur cost on all of these cases. How do we make sure that we work together in fixing this? Also, to the colleagues from VETS, it is not true that if VETS cannot tell what the department must do. We fought against PEPFAR to increase the budget to USAID and CDC. We fought with PEPFAR to make sure that more healthcare workers are hired and CHWs in order for that money of the Americans can be used to improve the quality of services in our country. We're calling upon VETS and other district support partners to say, we are on the side of the people. There is no middle ground here. It's the system and the people. There is no middle ground. Either if VETS falls on that side of the system or on this side of the people. When we say on this side of the people, some of the colleagues from VETS, when they are in these clinics, they think that they are the extension of the department. Some of them, we fought for them to be hired, but when they are there, you do not see a difference from some of them and the staff. That needs to come to an end. When our community see people from district support partners, they must see hope and someone who's going to assist them. So on that note, I hope that our meeting with the MEC will be secured, chairperson of the province, acting COO, and all of us. And on that note, besivule ngeslogan ke apha. Ayesaba magwala. Iyo esaba magwala. Dola. Tobola. Mama ngiyekele tobola. Siyabonga kakhulu enkosini ukuthi sonke ingazi ke uThixo woxola bekunye nathi asikhaphe siyofika emakhaya. I thank you all.